physio like hydronephrosis is concerned.
Yeah.
And if you look at the even guidelines, probably till 2010, if you look at the differential diagnosis of antenatal hydronephrosis with postnatal approach.
We are live now, sir.
Okay, fine.
And we are live on Facebook now. Yeah.
Okay, perfect. So we are live?
Yes, sir, you can go ahead, sir.
So friends, once again, I'm welcoming you all on this awesome platform that is Urology Learning Through Others' Experience, ULTOE, which is doing a fantastic job in this very much difficult time. Since last 7.5 to 2 months, we have more than 100 webinars or meeting and panel discussions and live operative, semi-live workshops and all those things. And hopefully you people have learned a lot and enjoyed. And today we have this exclusive session on pediatric urology with the Professor Margrit Fisch from Germany and a few of our excellent experts from India. So first I would like to introduce all of them. Professor Margrit Fisch is a fellow of European Board of Urology. She is a director and chair of Urology Department of University Medical Center Hamburg and fellow of European Academy of Pediatric Urology. She trained with Professor Rudolf Hohenfellner in Mainz, Germany. Her major scientific interest was and is reconstructive urology. She did major contribution on ureter reimplantation techniques and forms of urinary diversions using the anal sphincter. And I am the one. I started knowing you in 96, 97, performing the first sigma rectum pouch in our institute, and that was probably the first sigma rectum pouch, it is I can say, of our zone, that is a west zone of the India. And in 2000 she moved to Hamburg, taking over the position as the head of the section pediatric urology. At AK Hamburg, became director of the Department of Urology and Pediatric Urology for 2 years later. Margrit Fisch was president of the Society of Genitourinary Surgeons and the European Society of Genitourinary Surgeons, that is ESGURS. Among others, he is a member of ESPU, SPUS. Professor Margrit, thank you very much for accepting our invitation, and we all welcome you in this webinar. And we have a professor, we have Dr. Sripathi. He is also European Board Certified Pediatric Urologist. He is a Senior Consultant Pediatric Urology and Robotic Surgeon at Apollo Hospital, Chennai, and Director Pediatric Urology Fellowship Program. We have a Professor Ansari. No need to introduce Professor Ansari. He is a head of the Pediatric Urology Department at very prestigious institute, SGPGI Lucknow, and a very good friend of me. And he is a very much guide, which is a very much big guide for me in my day-to-day practice. And we have a Gyanendra Sharma from Solapur. He's a private practitioner with very much deep interest in pediatric urology. Have a few papers related to the hydronephrosis and approach to the postnatal approach to antenatal hydronephrosis. So we have a good panel today in this webinar, and I hope we'll be getting few questions live also, and that will be taken, and Nitesh will take care of this. So this is a case-based discussion today, and I'm introducing the first case. This is something about the bilateral hydroureteronephrosis. You can see that this patient was picked up with a bilateral mild hydroureteronephrosis at the 3rd trimester in a female of 30 years of age. And another picture is of a 4th day postnatal of a sonography, which is suggestive of a mild hydroureteronephrosis with the ureteric dilatation at the bladder level was a 5 to 6 millimeter. And there were no other issues other than this. Bladder normal, post-void residual was 8 to 10 cc, and during the pregnancy also the amniotic fluid was normal. So other than bilateral hydroureteronephrosis, mild hydroureteronephrosis, there were no issues. So before I go to the question, I just go through the EAU guideline for the postnatal approach. Now, what we do generally is the first sonography, that we generally do it in first week. And if there is a dilatation, we may or may not go for a VCUG. Now, this is the big confusing area where we will going to discuss. Now, what this 2020 guideline says that the diagnostic workup, including VCUG in this scenario, must be discussed with the caregivers, as it is possible that even if the reflux is detected, it may have absolutely no clinical impacts. And the other side is said that the 25% patients can have reflux. The second slide which I want to highlight is that antenatal detection and postnatal approach. The guideline says that the monitoring with careful sonography avoids unnecessarily invasive irradiating examination. And second statement is the first 2 sonography scan within the first 1 to 2 months of life are highly accurate for defining the presence or absence of renal pathology. So in infants with the 2 normal successive scan, VUR is rare, and if present, it is likely to be low grade. Now, based on these 2, in my practice, what I generally do for VCUG is that I don't jump for the VCUG in a first month. I generally put the patient on antibiotic prophylaxis, call this patient, say after 3 to 4 weeks, doing again the sonography, and if I don't see any progression of hydronephrosis, I still don't do VCUG. That is my first statement. And regarding antibiotic prophylaxis, we know there is a evidence on either side, or there is no any RCT, and the high-risk patients are hydronephrosis or high-grade hydronephrosis. Considering this fact, I put this patient on antibiotic prophylaxis. So these are my 2 statements. And now I would like to ask the Dr. Ansari that will you consider VCUG in this child? If yes, when? And if no, then why? What is your own practice or institutional practice, sir?
Yes. See, if you see, because ultrasonography antenatally is showing, even the postnatal also, I believe, is showing hydronephrosis.
Sir, can you increase your...
I am audible now?
Yes, now.
So it is very tempting if you see that ultrasonography is showing bilateral hydronephrosis. And there is only one longitudinal scan which has been provided.
Yeah.
I do not see any part of the pelvis. So I believe this has to be a SFU grade 1 at the most.
Yeah.
So if you see the upper tract dilatation criteria, 2010 and 2017 consensus by AUA, and which says if it is a mild upper tract dilatation, that you may not need MCU. But if most of the time, if we read the guidelines, when you see there is any radiological abnormality in terms of hydronephrosis or hydronerotor, then you go for VCUG. Up to this, seeing the findings on ultrasonography, I would not like to go for VCUG, which I feel is quite invasive in neonates as well as quite anxiety producing for the parents as well.
Okay, so you will hold on the VCUG.
Yes.
And what you will do? Will you call the patient for the sonography again, and what time?
Yes, I will repeat ultrasonography after 4 weeks. See the trend of this grade of hydronephrosis. Is the same SFU is maintained, I will be happy. I will counsel the parents, need not to be panicked. Just hold on.
Now, in that circumstances, what you will do for antibiotics? Will you consider for antibiotic prophylaxis or no?
As far as there is no history of UTI so far.
No, it is only 4th day. This sonography was done on 4th day, considering the antenatal finding.
Yes.
And then I'm starting from there onward. That this patient has come on 4th day with this sonography, with the past history, means antenatal history of hydronephrosis, and you are not going to perform VCUG. Perfect. You are going to call the patients after a month for a next sonography. During that period, will you consider this patient for antibiotic prophylaxis or no?
It is a male baby, uncircumcised, and there is a bilateral hydronephrosis, even if it is grade 1 SFU, but there is a hydronerotor also. So in the meantime, for intervening period, I will put him suppressive antibiotic.
Okay,
till he comes to the next.
Perfect.
Ultrasonography.
Would like to add anything or disagreeing with anything?
Okay. I mean, initially when you showed these scans, there's a little bit of difference between the 2 scans. When you look at the antenatal scan in the 3rd trimester, this looks like a UTD-A23. In the sense you're able to see some minor calyx dilatation also
Yes.
along with the central calyceal complex. But if you look at the longitudinal scan subsequently, we don't have a transfer scan here.
No, I don't
What
have
you're able to see is only a mild splitting of the pelvis, possibly a major calycis being seen here. Personally, my impression has been an intermittent dilatation of the ureter, not really that great. I don't think you need to really jump to anything. Within the newborn period, I would not give antibiotics because they are passively covered if they are being breastfed. After the first month is over and we subsequently do an ultrasound and find that we have a significant hydronephrosis, then perhaps we would give antibiotics. If we are thinking in terms of reflux, I would circumcise them at about 3 months.
But what about the VCUG, sir? Will you consider for the VCUG?
I wouldn't be in any hurry to do the VCUG at all, because it's really not going to change the management as far as this child is concerned. Even if we do a VCUG and see reflux, what are we going to do? Nothing.
Sir, why I raise this issue that when we are discussing this in our platform on ULTOE, most of the time we get this question. And what I have seen, many of the urologists or pediatric urologists or institutions, they adhere to the protocol of doing VCUG in the first week only. Correct. And in that circumstances, they picked up these kind of things. So I think we have at least two of you having a consensus that there is no need to jump on a VCUG. Professor Margrit, you agree with the VCUG?
Do you have my slides in? On case 1, you're forward?
Yeah.
Yeah. So we have a statement. This is a joint statement of the Society of Pediatric Nephrology here in Germany and also the Society of German Urologists. So what we do in cases with prenatally diagnosed hydronephrosis, we repeat the ultrasound at day 4 to 6 after birth. And you see, these are the parameters we'd like to evaluate. It's the thickness of the parenchyma. This was already discussed, echogeneity, and also the intrarenal diameter, and whether there is calical ectasy. So if this is okay and less than 1 centimeter here, then we would continue to do ultrasound controls. Concerning the VCUG, it's a little bit a difference in between males and females. So the recommendation of these guidelines is that in a males, you should do a VCUG to exclude urethral valves. Not in the females. In the females, you just do your ultrasound later on and then see how it looks like, and then follow the rules of the unilateral dilatation. I will have a slide later on. So what can be done instead of a VCUG, and in a case like you presented, I would recommend that, is just to do an ultrasound with the urethra and to see whether there is a dilatation or not. I mean, if you have a valve, you normally would have a more severe dilatation of the upper tract. So I absolutely agree. In this special case, I would not hurry.
Okay, perfectly. Okay, Gyanendra.
Yes.
Anil,
what I would do is, once I have a diagnosis or a report that the child was prenatally before birth having bilateral hydronephrosis and hydroureter, I would start antibiotic prophylaxis from day 1.
Okay.
Do a first ultrasound at around 5th day. It confirms the diagnosis, and you mentioned that the ureteric dilatation was about 5 to 6 millimeter, which is not much. So I would continue with chemoprophylaxis. My follow-up would be do a urine routine and sonography every month, and the moment the child is sick. If there is no increase in hydronephrosis or hydroureter, the child is free of infection, then I would not hurry to do a VCUG at least till he is 12 weeks old.
Okay, perfect. And what about the, Dr. Ansari, I'm coming to you. Professor Margrit, what about the antibiotic prophylaxis? Would you like to put this patient on antibiotic prophylaxis as there is a bilateral hydroureter is there?
Yeah. Can you forward my slides again? I think I have a, this is on ECG. Yeah, a little bit forward. No, forward. Forward. Okay. So it's really, that was okay. Go back, please. No, back. Yeah, no, once back. Okay. So this is an overview of the study. Sorry.
Which slide you want?
Anil,
No.
slide
The
which
one with the
mentions antibiotic
antibiotics.
prophylaxis.
Next.
Just stop.
Okay. So because no,
Just
this
one.
was too fast.
Okay.
Back again.
Is it okay?
No, one back
Yes.
and one back. Yeah.
Yes.
Okay. So this is an overview on antibiotic prophylaxis of the studies, and you see that it's really not really conclusive. In some studies, you have wide age range, low grade of reflux. In the other study, you had low grade reflux, uncertain compliance. In some studies, crossover was included, and the last study from Greg Peters et al., they just saw a benefit in the subgroups. So next slide. So from that literature, at least, can you just forward it once?
Anil, okay, next.
Yes. Sorry.
Okay. So just so from these study, there was not really a clear benefit for antibiotic prophylaxis. So if you forward.
Next.
Next.
I think Anil has a problem with internet.
Oh, okay, I see. So
Yeah.
next slide would be the VUR trial. So 607 children. And in the year 2018, there was a sub-analysis according to stratification to risk groups published. And there you really could see that there is a benefit for high-risk group. And there was a 3.7-fold increased risk for urinary tract infection on placebos, and the number needed to treat was 5 in a high-risk group and 18 in a low-risk group. So their recommendation was selective risk-based approach. So we have a child uncircumcised, it's young. Concerning the age, I would consider, and all the other issues, that this is high risk, and I also would put the child under antibiotic prophylaxis. And when we follow the recommendation of the EAU guidelines and also AOA guidelines, then at least during the first year, they recommend antibiotic treatment in these kids. Can you forward now, or is it still not working?
I think Anil has a problem with internet, sir.
Yes,
Yes.
Anil sir is having a problem with internet. Ansari sir and Sripathi sir, can you take over? Can you?
Yes, just yeah.
He's coming back again. He'll join in 2 minutes.
Okay, just to comment on while we were discussing on avoiding cystorectogram in this case. So there may be a question: when should you advise avoiding cystorectogram? So if you read in continuation with the same guidelines by AUA, there may be little difference between European guidelines and American guidelines. So in situations where we find signs of LUTO, lower urinary tract obstruction, like there is a gross dilatation of the ureters, posterior urethral dilatation, or bladder is distended or thick wall, then in that cases, absolute indication for VCUG. So these are 4 or 5, or even in megacystis also. If you find these cases or these findings on ultrasonography, in obstetric ultrasonography, then you may straight away go for VCUG. Otherwise, you just hang on. And yes, to discuss further the antibiotic prophylaxis, as Dr. Margrit nicely elaborated, because if you see the Cochrane review between 2004, 7 and 11, all Cochrane reviews, they said that all antibiotic prophylaxis, irrespective of grade of reflux, are not effective. So there was a confusion which was created because all these reviews were retrospective. So then in between, after, there were some good study design trial also, like PREVENT and Swedish trial. They showed some benefit of antibiotic prophylaxis. But as Dr. Margrit showed that RIVER trial, which was a well-designed prospective, a blind control study, which definitely showed a effect of antibiotic prophylaxis as compared to the placebo. And almost the trial has shown over 50% reduction in the infection, although there was no difference in the reduction of the rate of the pyelonephritis or scarring in these cases.
Yeah.
Dr. Sripathi, you want to add something?
No, I just wanted to say something that's very, very pertinent to the population group that we are treating here in this country.
Yes.
And considering that a wide number of people are in various centers with all sorts of various, problems,
Yes.
I would be very, very concerned sending a newborn for a VCUG.
Absolutely.
If it's a PUE, one of the things that we say, and it's worth emphasizing, especially when there are so many young urologists listening to us,
yes.
If it's a PUE and you find that the radiologist, you're sending it outside or even within your department to the radiology department and they confirm a PUE, you jolly well put a catheter at the end of the MCU.
Right.
Because we have seen children dying because this has been avoided, because the radiologist will take out the catheter, get you a voiding film, and then it's subsequently your responsibility to make sure. I think the problems of doing a VCUG, especially in infancy, are far, far higher than what we would really think about. And I would be very, very concerned about doing a VCUG unless it was absolutely necessary. If you're really concerned that the child that you're dealing with is a PUE, please go ahead. But make sure that you're there in the room, perhaps you're doing the VCUG, and you ensure that the child is catheterized at the end of that.
And I think another argument is that what's the therapeutic consequence? Because an investigation to me only makes sense if there is a direct therapeutic consequence of it. And you wouldn't do anything in the first year of life in a bilateral reflux except conservative treatment and antibiotic prophylaxis. So why to do it?
I think the point that Dr. Margrit Fisch has raised is extremely important, and that's something that almost everyone needs to carry on. Because we go to all these conferences around the country and we are appalled, and I'm sure all the panelists will agree on that, on the number of people who want to go in and jump in to treat reflux within the first year of life, and it's something that we would very much advise against. So it really doesn't matter. Even if you have major reflux, it doesn't really matter. Antibiotic prophylaxis perhaps may be the only way that you need to go.
Yeah, and when you look to the guidelines, there is a little bit of difference between the EAU guidelines and the AUA guidelines concerning antibiotic prophylaxis. So the EAU, the European guidelines, say initially treat all patients diagnosed within the first year of life with continuous antibiotic prophylaxis, regardless of the grade of reflux or presence of renal scars. And on the other hand, AUA says antibiotic prophylaxis is recommended for children less than 1 year of age with febrile UTI. And in the absence of febrile UTI in children less than 1 year of age, only recommended in grade 3 to 5 reflux, high-grade reflux. So, and if reflux is identified through screening, it may be offered. So it's really a bit a difference and a bit up to you.
So sorry, friends, I was probably disconnected because of some internet issue. Though I purchased for this meeting most fastest possible in India, that is Geo Fiber, but that has also ditched me. But anyway, I hope that you continued with the discussion and where exactly you are. So from there I start.
So antibiotic prophylaxis, yes. The last slide was antibiotic prophylaxis, yes.
Yeah.
Yes. Yeah.
Yes, in this patient, we'll give the antibiotic prophylaxis. Now, let us go to the second scenario. That is something like, it's a little different scenario where we don't have a urine tract infection. We have a unilateral hydronephrosis, which was picked up antenatally and postnatally in a workup. It turned out to be, before that, I want to highlight this issue. Sorry for that. That in these patients, see, we picked up this reflux of a low grade and a low risk case. Now, see, we have diagnosed. Professor Ansari, would you like to treat this patient? And how long you will treat and how long you will follow up and how you will follow? Because see, this patient is investigated, passed through the traumatic investigations, now and irradiating investigations. Now your lower risk reflux is there. So what next?
So I agree. The best thing would have been not to do VCUG. Since it has been done, now the reflux is there. So we
Right.
have to honor this. So
Yeah.
consensus has arrived among the panelists that the antibiotic prophylaxis has to be executed.
Okay.
But the question is how long this has to continue
One.
and how to further follow this.
Follow.
Because in cases of mild UTD, upper tract dilatation, so there is no risk that this is going to damage the upper tract so easily in these cases. While if you are having a UTD of mild grade, then the chances of this infections in this age group is only 3 to 5%, very low risk. So while maintaining antibiotic prophylaxis, ultrasonography, I feel, will be sufficient to monitor this.
Okay.
And you have done one DMSA scan also. The baseline scan is also showing a smooth contour. There is no any scar or photopenic area. So need not to worry, or I don't think it will be needed to repeat at all. The ultrasonography itself will be sufficient.
The leading question is that how long you will continue the antibiotic prophylaxis?
But not only the
before you
antibiotic
end the antibiotic prophylaxis, will you repeat the invasive and irradiating infection investigations, or you will stop it on one time and then you will repeat only this investigation if there is a UTI or febrile UTI?
Because it is a male child, you have to teach him the preputial hygiene. Unless you go to the philosophy of Dr. Sripathi that he will circumcise him.
I will also circumcise.
So, okay. So if not circumcised, because many Europeans may not like to do circumcision, Dr. Margrit will comment further on it.
If the child is less than 1 year, the child is less than 1 year, and I am observing this child,
yes,
I would prefer to do circumcision.
Okay. So I may not prefer it. I may not prefer it. So I will teach the parents the preputial cleaning, hygiene, perineal hygiene, very important. And I will also observe this child that this child does not develop any lower ureteric symptoms, a dysfunctional voiding. The bowel habits are normal. Antibiotic prophylaxis alone execution is not sufficient. You have to monitor other things also. Otherwise, if those things are there, whether it is he's getting infected because of phimosis or because of the bladder bowel dysfunction or because of the poor bowel habits, then antibiotic prophylaxis is not going to take care much in this child. The second question is how long you will follow and what methodology you will utilize in this kit. So I think ultrasonography will be sufficient to repeat at 6 months in mild upper tract dilatation. That will give you, if it is not increasing, then you can sit silently and confidently. May counsel the parents accordingly.
And when you will once you stop this, at that time, will you repeat these invasive investigations or no? You will just be relying on the sonography.
I think one DRCG can be done at the end of 2 years.
Dr. Sripathi,
yes.
You consider a radionuclide cystogram, something like that, or you will just stop at one juncture and then you will repeat only if there is a UTI?
Sure. Can I just make a few comments? One is this longitudinal section of the bladder can you see the pointer? The longitudinal section of the bladder that you have there, your ureteric dilatation that you are able to see on the ultrasound is not commensurate with the grade of reflux that you have here.
Right.
That's a fairly significant dilatation of the ureter that you see there. And here the comment as far as the MCUG is concerned, the bladder is overfilled.
Yeah.
And not only that, you can see this is a child done at the 6th week. You can see that just that the posterior urethra is opening up, but subsequently everything seems all right. We adopt a top-down approach. We look at the DMSA first. And if the DMSA is normal.
In this particular case, no, sir, I just want to stuck to this case right now.
Sure, sure. What I would do is I would circumcise this child. I would keep antibiotics subsequently for about a month or 2 months and then stop it. Primarily because the moment you've gone this far diagnosing all this, the parents want something to be done. And they wouldn't be happy if you just said, no, it'll become all right. Then why the hell did we do all this? So I would sort of circumcise them, keep them on antibiotics. The follow-up will be, as Dr. Ansari has said, with ultrasound. I would not do a DRCG because a DRCG requires a lot of cooperation from the child.
Okay. So we have a consensus that we'll not do irradiating investigation.
No, I don't think you need to do. If the kidneys are growing.
We stop antibiotic prophylaxis in developed UTI, then we may consider doing either top-down or bottom-up approach.
If after stopping the antibiotics you get a UTI, I think you have to repeat your MCU again.
Agree.
Without a doubt.
So the thing is that till now we have seen ample number of patients who come with the 1 or 2 or 3 VCUG, whether the reflux has disappeared or not, and that is much more traumatic rather than the any treatment which would have given. Now, anybody is having a last question on this particular case. Is anybody is having a distal thought about doing deflux in this patient at the almost age of 1 year, if the reflux is not disappeared for this grade of reflux? Because many of these our articles are there where people have mentioned that the result of deflux is very good in a grade 1 and 2 or 3 like that. So that means people are treating grade 1 and 2, which I have never found any necessity in my practice, at least of more than last 15 year practice. So any comment on why the deflux and why the people are opting for the deflux in this kind of cases? Because many of the article, they don't dissect the patients further. They said that they treated grade 1, 2 like this, whether there was UTI or not. Any comment on that overuse of deflux or anything?
I think there is no need. I mean, if you wait in a reflux like that, it will disappear. So, and if the child is asymptomatic, why to do anything? So I just
Professor Margrit, have you ever seen other people are practicing deflux in this kind of a scenario?
I know that in the Scandinavia, there are a lot of people doing something nonsense like this. To me, it's a nonsense, really, because if a child is asymptomatic, I mean, it's a young child. The probability that this reflux, and I will have later on a slide on the resolution of reflux, that this reflux will disappear is very high. So why should you do anything to do with that child? I mean, we have the problem in Germany that the mothers don't like to have the boy circumcised. So that's the reason why in these kids we put them under antibiotic prophylaxis, but just at least for 1 year, and then you can discuss it. And if you have a good compliance of parents, you just can give them some sticks to chip the urine and say, okay, if you have the feeling that the urine is smelling, or you have the feeling that something is wrong, just check the urine, and if you see that there is an infection, come to the hospital, and you even can stop antibiotic prophylaxis. Because, I mean, we haven't yet discussed that, but what is the compliance? And there are also data out.
Absolutely.
If you put them under antibiotic prophylaxis, how many really give them to the child? And the second thing are local conditions. That means the microbes that are around, you give them a standard antibiotic treatment and it doesn't work at all, because you have a high resistance of your microbes. So in your special area, at least we do that in Germany, we always talk to the microbiologist what type we should use. Yeah.
So, and the last question or last argument, many of the time in discussion I have seen that they said that because of compliance issue or having a problem of giving daily dose, rather than why not deflux, even if it is working in 50% cases, what is wrong into that? We can avoid these things.
Can I just answer that, yes, Anil?
Yeah, is it holding this argument?
Anil, this seems to be a particular American devilish invention, this bloody deflux.
Agree, sir.
Because primarily, I will tell you, in the type of reflux that you have shown here, this is an overfilled bladder with a reflux that is probably, about grade 1. If you really push it, it'll be grade 3. I wouldn't care. This whole thing will settle down once the child is toilet trained.
Agree, sir.
Now, before the child is toilet trained, this child is having high pressure voiding. Now, what sense does it make to actually go and put deflux and block both the ureteric orifices and suffer all the problems of deflux in the long term, including calcification at that point? Because a lot of times when we redo reimplantations on these children who have had deflux, there is horrible calcification at that particular point. How are we even justified in subjecting a small infant to this sort of a horrible abuse? I think it's just not warranted at all. If there is a message that needs to go across, so the answer is please don't misuse deflux.
Absolutely, sir. Agree. And we passed the most of the messages related to this case. So moving to second case very quickly. Here, see, what I exactly want to discuss is this is something different scenario.
Yes.
Where we have a antenatally detected gross hydronephrosis on the one side, right side or left side, and then in postnatal without having history of urinary tract infection, as the sonography is still showing the smaller kidney with thin cortex with little bit of increased echogenicity with severely dilated ureter. Will you consider this patient for further investigation, Professor Margrit? This is a scenario. There is no UTI. This patient was just picked up in antenatal third trimester, and postnatally, patient has approached to you at the 6 month with a similar sort of sonography, having a smaller kidney with increased echogenicity, with thin cortex, with gross hydroureter. Will you consider for further investigation in this patient? If yes, what?
I just would do a DMSA to have an idea about the kidney function, and maybe you can forward because the slides, or would you like first to discuss it?
Yes, yes.
I would do a DMSA to know about the upper tract, because my suspicion would be that this is a completely different entity. This is a congenital reflux with dysplasia. So this is something completely different from what we discussed up to now.
Coming to that, and I think, but I assume all of you are agree that at least we have to investigate further this child by doing the DMSA scan as well as maybe probably voiding cystoscopy. So in my practice, I have almost 10 to 12 cases which is detected over the span of 10 years with this kind of a scenario where we have a unilateral huge hydronephrosis with a small hydronephrotic kidney with thin cortex, and DMSA scan when I do, there is a global reduction of parenchymal mass without having any polar photopenic area or absent activity, which is I do not categorize as a scarring or scar. Now, what could be the possible reason, Professor Sripathi, Dr. Sripathi, for this kind of entity?
I think I would completely agree. Completely agree
before
with
Dr. Sripathi answers, may I put a question to him?
Yes.
Because he has been, you have been talking about the top-down approach, and the ultrasound shows only a small-sized kidney with no hydroureter. So would you do a VCUG in this patient, or would you go by a top-down approach and then your management would be altogether different?
Here is a 6-month-old child who's not had any UTI. We know that this child has got no UTI.
So there is no question of doing top-down. Top-down, we I think assume that when there is a UTI, we want to know whether it is a high-risk patient or not. Fine. And if we do DMSA scan, if it shows some photopenic area without contour or with the loss of contour, we assume that there is a high-grade reflux or a high-risk patient, and then we do VCUG. So we are coming to that point. But in this patient, I approach with the VCUG first and then subsequently DMSA scan to quantify the damage and to explain the parents.
I think primarily this is a dysplastic kidney on the right side. Whatever you do, that's not going to improve. The opposite kidney has already compensated, looks fine. Perfect. I would circumcise this child and then keep quiet.
Okay, perfect. I agree. Now coming to the point, what are the possible reasons for this? Do you think that it is a disorder organogenesis, or it could be because of transient in utero infravesical obstruction? Because this entity is entirely seen in a male patients, and very rarely 0.6% it is seen in the female patient, but most of the time it is seen only in the male patients.
I think this is just disordered renal dysplasia, a problem in development. If you were to repeat the MCUG at about 3 years, you would find that the reflux is gone on that side, and possibly the kidney has become smaller. And that's
I agree, because literature do mention that, but I have not done. The reason is that this, in my practice, I have not seen this patient develop urine tract infection. So coming to that point, Professor Ansari, that will you consider this patient for antibiotic prophylaxis or not? And secondly, what will be your management approach to this patient? This is a patient with a congenital nephropathy associated with the high-grade reflux unilateral. There is no history of urinary tract infection, and for that reason, I would like to show these at least I could accommodate 3 or 4 patients in this particular slide, because I don't wanted to increase this number of the slides. So otherwise, I would wanted to include 10 to 12 patients, because here my practice, in my practice, I don't consider these patients for antibiotic prophylaxis, assuming that these dysplastic kidneys, severely dysplastic kidney, leaving this patient do not have anything to respond to the onslaught of infection, which is coming from the bladder because of high reflux. And that's why I don't think there is any role, because this is simple. This is just like a conduit where you have a severely dysplastic kidneys are there. It has nothing to do with the onslaught of infection. Am I right? or what is what you believe for treatment or approach to these patients?
So most of the time, the answer in dysplastic kidney lies in itself. 5%, 2%, or 8%, less than 10% function. How do we expect that this kidney will be making urine and the antibiotic will be excreting and to sterilize this tract? Since these kidneys are hardly making an urine, so antibiotic should not reach. So the philosophy of use of antibiotic prophylaxis should not work in such kind of kidney, because these dysplasia are congenital, and which are more common in male children rather than the female children. So these are all developmental defect, which could be on account of genetic disorder, could on account of some drug induction or drug application in antenatal period, or it may sometimes may be because of high grade of reflux due to the water hammer effect. So this is not the kidney which has after pyelonephritis. So this is basically a primarily developmental defect, and they do not produce any urine practically. So antibiotic prophylaxis should not work in these situations.
Perfect.
Yes. And secondly, what should be done those who are troubling because of the reflux? Then the answer is usually you monitor them in terms of proteinuria, hypertension, or if there is a recurrent infection, then you have to do nephrectomy in these cases.
Perfect. Professor Margrit.
Yeah, can you just forward the slide?
Forward.
Yeah.
Should I?
Yeah, just that everything is okay. So this is what already was said. So we really have to differentiate between congenital primary vesicoureteral reflux and what we described as a connatal reflux nephropathy. And this is completely different. The only thing is at the end, at least the potential complications are the same. And I exactly agree. So I would leave the kidney in place only if there is a complication, because what we have seen in a couple of cases is that this high-grade reflux on one side is masking a lower reflux on the other side. And it's like a kind of air chamber. So as soon as you remove the kidney with the higher reflux, and then you get the reflux on the other side, and that's a little bit an argument for me. If it's a boy, and this normally is a boy, not uncircumcised, I absolutely agree. The risk of getting an infection in that not functioning kidney is low. But in a couple of cases, there is also contralateral reflux. So for the first year of life, I would do an antibiotic prophylaxis. And as I said, I would be careful with doing a nephrectomy. And if you do a nephrectomy, you have to follow and really do ultrasound and check the other side.
Okay. So the thing is that I agree with you. I go back one slide. See, in this patient, though this MCUG picture is not very clear because of bowel gaze, but there was an opposite contralateral grade 2 reflux, and this patient was having a febrile UTI also. Other patients were not having this kind of a problem. Now, suppose Professor Dr. Sripathi, you have a one side congenital nephropathy which relate with the almost uptake still of a global reduction, but uptake of around 15 to 18% with the contralateral grade 2 reflux with the history of febrile UTI. What you would like to do? You will be reimplanting on both the side, or you will be doing reimplantation and nephrourectomy other side, or what else?
That's a tricky. And how old is this child again?
Again, this child is.
Oh, sorry. Okay, various ages. Okay.
1 year.
Yeah. I would still be a little hesitant.
I just give you exact age of this patient, just 2.5 years. Yeah.
Okay, I'd be a little hesitant to reimplant below the age of 2.
Yeah.
Primarily because I'm a little worried about the size of the bladder and putting the ureters inside the bladder.
Yeah. No. We are coming to that point here.
Okay. So having taken that into consideration, if there is a bilateral reflux, I would tend to do a bilateral reimplantation. Having opened the bladder, I would do a bilateral reimplantation. I wouldn't leave out the dysplastic side at all. As Dr. Margrit Fisch has very clearly said, you do follow them up. As Dr. Ansari also has said, you do follow them up. If you find that they subsequently have hypertension or proteinuria, which is related to the dysplastic kidney, then that is the time that you would consider doing something about it. Otherwise, you would just leave them alone. If they are non-hypertensive, if they have no UTI, and if you are otherwise the kidneys are growing, I would just leave them and just leave them alone.
So message we wanted to pass is that these two are different entity, post-UTI reflux nephropathy and the congenital nephropathy. And accordingly, I think that we have to take this thing also. This is this slide which I highlight many of the times in many of the meeting. In 2013 in Vancouver, Margrit Fisch was there. This was my one of the presentation that we need to really have a right nomenclature for the lesion seen in the DMSA scan in a presence of reflux. See, what happen in the most of the time in literature is the terminology used commonly is the scarring. And to my mind, we have to classify lesion seen in the DMSA scan of reflux patient, acquired and the congenital, and acquired subsequently classify in a like this acute photopenic area without loss of contour, which is representative of acute inflammation, and this kind of a polar area where we have a loss of contour with the less uptake or absent uptake only should be qualified as a scar, and this is as a reflux congenital nephropathy, which is suggestive by the global reduction of parenchymal mass, where is nothing polar or eccentric. Are you agree, or you would like to disagree with this or highlighting further, Professor Margit?
No, I think that's right. The acquired scars normally on the upper and lower pole, and this goes back to very early work of Philip Rensley, whereas as you see in the congenital hypoplasia, it's altogether a small kidney. I absolutely agree. And if you also compare the voiding cystogram, you see the differences. So in the acquired renal damage, you see that you see all the three groups: upper pole, middle part, and lower pole. And in the congenital hypoplasia, you have a complete different picture. Yes. So I absolutely agree.
There was a paper in the 2009 supplement of Journal of Urology or like something like that. I've forgotten the name of author, but the title was "What is in a name?" That the what he wanted to give a message that we must not use the scar as a terminology to describe all the lesions which we are seeing in patients of reflux in the DMSA scan. For the proper diagnosis, treatment algorithm, as well as explaining the prognosis to the patients and parents.
Dr. Anil, can I just add one small point?
Yes, sir.
I think this is a very valuable thing that you're pointing out.
Right, sir.
The top one where you have said acquired during acute pyelonephritis, right. That's an acute phase DMSA.
Right, sir.
And I would strongly recommend that, that we ask our pediatric colleagues to do this, because when they have a febrile UTI, and if you can document a pyelonephritis, then that sort of dictates how long you would give antibiotic prophylaxis subsequently. Right. And that's a very valuable pointer to the type of management that you would do subsequently. And it sort of highlights also the seriousness of that febrile UTI. Okay. Because most pediatricians or pediatric nephrologists are a little hesitant about an acute phase DMSA, and I'm happy you pointed it out.
Sir, the problem is that, let us now finish that area of discussion, that the problem in my area, or probably in India, most of the time what we get in the patient from the pediatrician is that 2 to 3 times patient get admitted or treated at home with the higher antibiotics for the febrile episodes, but they never investigate child for the underlying urine tract infection.
Absolutely.
And when patient comes to us on 3rd or 4th episode, we realize that it was because of febrile urine tract infection. These pyrexia were there.
Absolutely. Absolutely.
And we are at that level that pediatricians still are not considering the urine investigation while they treat or put the patient on antibiotics for treating the febrile episode. Now, trying to convince many of the pediatricians that at least you perform ELI test, which is not difficult, leukocyte stress test, which is a dipstick test, or nitrite test with a dipstick together. And if that turned out positive, then please do this. And from there, you are taking one step forward, which I do generally believe that if given an opportunity to me, though I don't have a DMSA scan in Junagadh, Gyanendra is not having a DMSA scan in Solapur, but you have a DMSA scan in the Chennai in your institute. Professor Ansari is also having. Professor Margrit is also having. Now, what is your overall approach? You are well convinced with the top-down approach to reduce the amount of VCUG as well as not to detect the clinically insignificant or low-risk patients, or you still continue and believing the bottom-up approach? Dr. Ansari, start with you.
So we have been following the conventional one, that is the bottom up. That is, we first subject the VCUG, and if that shows the reflux, and sometimes we advise both the tests together depending on the case scenario. If the patient has come with multiple episodes of UTI, what else do you need? You will not ask the patient to make multiple visits to the hospital. The patient, parents, young parents who are coming from 1,000 kilometers, you will not ask them to take another appointment, which will be usually 1 month apart. So sometimes you have to take into consideration both. You advise VCUG and DMSA together. But most of the time, if it is a cold case and compliance is good in this family and the baby, then we advise VCUG first. If you find reflux, then we go DMSA. But I find in my practice, most of the time, depending on the ST, we advise both the tests together. So that saves visits as well as the money to the patient.
Perfect, perfect. Professor Margrit, what is your preference? Or you individualize as per the case?
We don't do the as it's recommended by the AUA or also the NICE, the down approach. So I also would do a VCUG, and then depending on ultrasound and also VCUG, follow the child. And only rarely we do a DMSA, only if we like to see whether there is a decrease in renal function. It means if we see in the ultrasonography any change in the upper tract, then we would do DMSA. We don't do it in the acute pyelonephritis, and it's also not our first investigation for reflux.
Okay. Now, suppose patient of 3 years of age come to you with the first detected febrile pyelonephritis. Still, you will go with the bottom up, or at that particular circumstances, you will consider DMSA first, and then you will decide, you will take a call on VCUG. Yeah.
No. Bottom up.
Okay. Professor Dr. Sripathi.
Yeah, no, my philosophy is slightly different from what Dr. Ansari and Professor Margrit Fisch have said. I'm calling upon a scenario where you have a child with a febrile UTI in the ward. You ask for an ultrasound and they tell you one kidney is slightly bigger than the other. They also tell you there is some sort of thickening of the pelvis. There's evidence of pyelitis. And that is the sort of situation where I would utilize when the fever comes down to send the child for a DMSA, and then we would know what is happening. If we see the type of situation that you have shown there, and we have seen that quite often, that's an acute phase DMSA, which shows that we are dealing with a fairly severe UTI. I would do a VCUG subsequently when the child is afebrile and comes for follow-up. Because there is the possibility that in the acute phase, when you do a VCUG, you are going to diagnose more reflux than what you would normally. But you have told the parents and the pediatrician that this is fairly serious and that needs antibiotic follow-up. This needs to be followed up. So they are sort of, when you start antibiotics also, Dr. Margrit Fisch was talking about compliance. This is the sort of case where they would be very compliant if you subsequently
so I tend to agree with Dr. Sripathi. In my practice, I see very sick child, 3-4 episodes of febrile illness. And at that time, VCUG is very difficult to even explain parents what is wrong going on. And they are very much apprehensive. At that time, though they have to travel 100 kilometers to a nearby center to get the DMSA, but once there is a DMSA, once the fever subsides and they see some lesion, it is very difficult to communicate with them that there is some serious thing is going on in your child's kidney. And now you will be on antibiotics for this much of time. And once you are almost clear of infection or reasonably clear of infection, I will do this VCUG test, and where we will do further things if with the reflux detect. So this is, I do believe. Yeah, Professor Margrit.
I'd just like to comment, we don't do the VCUG in the acute infection. So we treat the infection first, and then 3 weeks later, we do the VCUG. But never ever in the acute infection. I absolutely agree, this is dangerous.
Professor Margrit, how to address the anxiety of parents? They have come 3-4 episodes of febrile episodes. child is not thriving, child is very sick. At that time, do you think that we need to show them? We have to prove them by some investigations, some concrete investigations. We can.
You see, we are in a very comfortable situation in Germany. So we have very good healthcare available, and we have parents, they really take care, and everything is covered by the insurances. So I think that makes a big difference. So we treat the infection first together with the pediatric nephrologist, and when they leave the hospital, they already get an appointment to have the VCUG done, and then we have the diagnosis.
Perfect, perfect. And Dr. Ansari, you want to add last comment?
Yes, I just want to know if the child, if the baby is sick, the clinician's job is to take care of his urosepsis and dyselectrolemia. All tests have to be done except ultrasonography at a later date. That is the simple thing which.
Agree. So here I and Dr. Sripathi are telling 8 to 10 days after, once we put the patient on antibiotics, we are not recommending on the first, second or third day. Once the child is relatively off of the acute infection, and during that period, if we do this upfront DMSA scan, then only it is a acute DMSA scan. But okay, perfect. So coming to the next case, that again, the classical scenario which I witness in my practice, maybe you people also witnessing, that 3 times missed the febrile urinary infection, and then 4th time it was picked up, and then subsequently creatinine was normal, USC bilateral hydronephrosis, patient is on antibiotic prophylaxis. Go ahead with this bottom up approach. This is the VCUG of this patient, and you can see that this is a female patient, and this is the bilateral polar absent activity, classically suggestive of scarring. So this is the scenario. Here you can see VCUG film. This is the DMSA scan. And my question is, how will you treat this patient? Dr. Gyanendra, you have this scenario in a female child of a 12-month.
Anil, very common scenario. If you can go back one slide and show the VCUG.
Yeah.
If I look at the left-hand side film, I'm not very happy with the way the bladder neck has opened.
Yes.
There is a dilatation of the urethra.
Yes.
And this is what rings the alarm bells in my mind.
Yes.
And I would, though you have mentioned that there is no constipation, there are a lot of factors that I would look into it, because if these factors are taken care, especially the dysfunctional voiding part, though at the same time, I would have to confess that to pick up dysfunctional voiding in a 1-year-old child would be very difficult. We'll have to look at the history, ask the history to the mother very, very carefully. But if one is able to pick that up and take care of the bladder dysfunction and put the child on antibiotic prophylaxis, many of them would do well in the long run.
Perfect. Agree. So thank you very much for giving attention to that VCUG film, which is very much suggestive of something dysfunctional voiding is going on in this child, which is very difficult to derive from the clinical history. Yes, Dr. Ansari, what is your say on the treatment?
So most of the time I find BBD's Indian context is little misnomer.
Yeah.
In Indian patients are not that much constipated. If you see, even if there may be some bladder dysfunction, nearly 60% will be having 80% will be having normal bowel habits. So finding constipation is relatively less as compared to our Western counterparts.
I agree.
So this may not be related to BBD typically, but bladder dysfunction may be there. And the commonest bladder dysfunction in this age group may be the diffuser overactivity, which might explain. Can you see not only the bladder neck, more than the bladder neck, bladder size is more worrying in this case, small capacity. If you fill the bladder, maybe that the right side may become grade 3 and the left side will become grade 4 reflux. This has been partially filled bladder. So this is higher, and the kidneys are already polar scarred on both the sides. So in that way, the bladder dysfunction is also evident in this. And nearly 30 to 40% kids in this age group might have, especially in cases of bilateral reflux, underlying bladder dysfunction.
Okay.
One more point which I would like to add here is my experience of finding a difference in the bladder bowel dysfunction amongst the rural population and those who come from the urban setup. I find that the bladder bowel dysfunction is much more commoner in the urban population as compared to the rural setup. And
Agreed.
especially I would like to stress, and I'd like to know the opinion of the panelists regarding the use of Western toilets in young children. And I find that sometimes it is quite contributory because of the way they sit and they cause spasm of the perineal muscles. So I would like to have the opinion of Dr. Ansari sir and Dr. Sripathi on this particular point.
We agree about the potty training. Yeah. Dr. Sripathi, will you elaborate on this?
No, I think this is, we are forgetting that this is a 12-month-old child. You basically have to tell the parents that they have to potty train. Typically, a scenario is here is a child who will refuse to sit and stool, and that's about all. And you will find that, that most of these problems will just settle down the moment you potty train the child. That I would just potty train, put on antibiotics, and that's about it. Nothing else. Okay. Now, the problem is putting a small baby on a toilet itself is very difficult. You would have to put them on a small, a potty that's available. And today, most children for potty also, they require a TV. So perhaps you have to factor that also. Apart from that, you really can't put them on a very big toilet. Yes. And it becomes that itself can provoke the development of severe bladder bowel dysfunction in the long term. So I would just tell the parents, because they have not been concentrating on potty training, to start it very, very urgently. And this is a fairly severe situation. For this reflux to have caused this amount of scarring on both sides, it's fairly severe. I would urge them to be very serious about it.
What is your management approach? Means, how will you treat this patient?
That's a very good question. I would sort of, focus on the constipation now, see how much of stool retention there is. If there is stool retention, I would get rid of whatever stool
According
is there.
to parents, there is no much issue of constipation. And also, you can see in this MCU picture.
I wouldn't see this X-ray is only a snapshot in time. Yeah. Fundamentally, for a child to have this amount of dysfunctional voiding there, okay. This child must be quite severely associated with constipation also. I do agree. On the picture that you have taken, you can't see too much of rectal stool, but I would like that clarified a little more. I have a feeling the moment you clear the stool and put them on appearance, this child will just settle down. Okay. This child will just settle down.
Agree. So what you are proposing is that to train the potty training.
Correct.
Little bit of treating the constipation,
kind
of a dysfunction, treat that, and then you will put a patient on antibiotic prophylaxis and wait.
Correct. Okay. Remember, in this particular case, I don't think we should confuse the bladder bowel dysfunction in a 12-month-old child. You can't really talk about proper posture during stooling.
No. Only thing is that this is alarming. This
is quite severe. That's quite the amount of bladder distension. I mean, the amount of scarring that you have. Yeah, that's quite scary. Scary. This is the sort of child that I would keep a very close watch on. As Dr. Margrit Fisch said before, I would emphasize the importance of regular giving of the antibiotics. I would emphasize the potty training, and considering how laid back most people are on potty training, I would make sure that that is being properly followed. And once you do that, then I'm sure this child's reflux will settle down, though the scars.
I think, sir, we can explain this scarring because of previous 3-4 episodes.
Correct. No, this is one of the problems in our country, as you rightly pointed out, Anil.
Treatment as well as delayed treatment, which is led to this
absolutely.
To me, I think.
At least in our country, the first UTI that they talk about may not be the first UTI at all.
Yeah. Professor Margit, your say on the management.
Can you forward the slide? As we have nowadays really a risk approach. So we always have to consider the degree of reflux. And as you already mentioned, bladder bowel dysfunction, this is very important. I haven't found big information on that, therefore I haven't put a mark in, but if the child has bladder bowel dysfunction, the risk is even higher. And I absolutely agreed with what was said. If this child has bladder bowel dysfunction, this has to be treated first. However, it's an infant, it's a female. The child had recurrent urinary tract infection, and as far as I understood from the history slide, this child also had breakthrough infections, and the child had renal scarring, and the child is older than 1 year. So I must really say, as I said, bladder bowel dysfunction has to be excluded. But if this is treated or really excluded, I would discuss surgery in this case, because this is really a high risk child. Yeah.
Okay. Would you like to discuss this slide?
Yeah, so I mean, this is what the EAU is offering or recommending, at least, offer definitive surgical or endoscopic correction to patients with frequent, breakthrough infections. Then offer open surgical corrections to patients with persistent high-grade reflux and endoscopic correction for lower grades of reflux. Offer a surgical repair to children above the age of 1 presenting with high-grade reflux and abnormal parenchyma, and I think that's this case. And offer surgical corrections if parents prefer definitive therapy to conservative management. So this is really a child I would discuss with the parents whether it's better to do surgical intervention. As I mentioned, there has to be bladder bowel dysfunction excluded or treated. This is the precondition.
Perfect, perfect. So I have not mentioned in the history, but this VCUG picture is a little bit of suggestive of some underlying voiding dysfunction, which we have to predict in this patient.
Anil.
So, okay, Dr. Ansari, would you like to?
Yes, I just wanted to say there is one viewer who has commented why it cannot be non-neurogenic bladder. One of the viewer is chatting.
Yes.
Yes. Just I think why it is not non-neurogenic bladder. Why we call it BBD now?
No, it could be, but it is very difficult to.
Let Dr. Margrit reply, because this is an old terminology. Then change to Fowler syndrome, now to BBD, Hinman syndrome. So many synonyms have come in between.
Yeah, I think we will later have a case of a distended bladder with a high-grade reflux.
Right.
So maybe we can discuss it during that case.
Okay.
But what we would do to get a little idea about the bladder function is really to measure the thickness of the bladder wall with a full bladder and an empty bladder. And it's difficult, but in a 1-year-old, you should manage to do it, and then you get a bit an impression how this looks.
Okay. So, agree that you will offer the surgery, and I also perform the surgery in this particular patient, considering the demography and overall socio-economical circumstances of my area. That I would like to remain safer on the side of this patient, as patient is having a bilateral extensive damage. So,
Anil, can I just sort of quickly intersperse something? In a child who's got a bladder bowel dysfunction, we are talking of a different scenario in Germany. In a child who's got a severe bladder bowel dysfunction, this is primarily a child who's not potty trained, or the parents have not realized how much holding maneuvers this child is doing. Along with starting potty training, I would consider endoscopic management rather than surgery per se, because potty training is something in evolution in a child who's 12 months old. It's going to be quite difficult to get it to potty train. What happens if you subject them to surgery?
And endoscopic procedure, that is one of the contraindication for
No. What I'm trying to say is, I take Dr. Margrit Fisch's point that this is fairly severe scarring on both sides. Maybe with recurrent UTI, you're going to possibly hasten end-stage renal disease or whatever it is if this continues unabated. I would do agree with that. But before actually jumping into surgery, I would consider endoscopic treatment, not forgetting the primary emphasis on potty training or the treatment of bladder bowel dysfunction in this case. It has to go side by side. It is not something that you would sort of, no, I would just offer surgery. No, not in our context, because our people are really not going to. They would just do this, and the child would still
why I didn't offer the deflux? The reason is that I was looking to my experiences as well as the literature. I was having a chances of failing around roughly about say 40 to 45%. And
absolutely, I would agree with you. What makes you think the failure rate will be less if you do surgery in a child who's got persistent bladder bowel dysfunction? Come on,
no.
Here is a child who's not potty trained. Please don't forget that. You should not look at the DMSA scarring and jump in to say, no, I would offer surgery because some guideline says that. Don't forget potty training and bladder bowel dysfunction in this case.
Sir, results of bilateral reimplantation, open or any method,
Yeah.
in a patients with underlying BBT are quite excellent.
They
is
would,
not much affected by
but
the BBT.
it
But
has
if you
to.
go for endoscopic treatment, there are high chances of failure. It is very much non-thing.
What I would say is,
Let us mark it to
yeah, sure, absolutely,
comment on this.
absolutely, absolutely.
Yeah, please.
Madam, please.
Yeah, as I said, bladder dysfunction has to be treated first.
Ah.
And that's the statement I did. And Anil, I'm not sure whether you have exchanged my slides, my discussion slides.
No.
I said
that is coming.
Then go forward. I don't know what the next one is.
Because next case is having an obvious history of bladder bowel dysfunction. So that is coming. Here, why we have diverted this discussion, looking to the MCU film.
Could you just forward one slide?
Okay.
So because we discussed bladder dysfunction, open surgery and endosurgery, and this slide is a slide from Greg Peters, who gave it to me. And you see in the upper line, this is the open treatment. On the left side, in cases with bladder bowel dysfunction and non-bladder bowel dysfunction, and you see that at least the success rates are quite the same. If you look to endourology here, and you see the reflux resolution in those children who have bladder bowel dysfunction compared to those who have not bladder bowel dysfunction, you see a difference. And that means that the endoscopic treatment in those population of children is worse if you do endoscopic treatment compared to open treatment. And that's the reason why I offer surgery.
Absolutely. Perfect.
Well
this
done.
Is from the AOA guideline panel.
Well done.
Okay. Dr. Ansari, we are moving to the next case where we have again opportunity to discuss this. Most of the things are discussed probably on the BBD. I wanted to bring this BBD issue in this particular case. So if you want to escape, we can, and we go on a discussion on now further on this. This is all we discuss. But now here I want to highlight here. This is the 8-year child, and probably the reflux is not resolved and given rise to the bilateral scarring. Could be the reason of severe constipation as well as the dysfunctional voider, means he was lazy voider and many other issues which we have addressed. And now here I want to bring the discussion the choice of reimplantation. Whenever in these two patients, suppose if we go for a reimplantation, one patient is of 1 year age, another patient a little more than 1 year, and this patient is of 8 years. What will be the choice of surgical approach, Dr. Ansari? In a first case, if you plan reimplantation, in a second case, if you plan a reimplantation.
These are of the same patient, all 4 images.
Yeah, no. This is the another patient of 8 years, right? We have decided to operate this patient. In a first patient, we also at 1 year or 14 months we decided to operate. Now, what will be your surgical approach if you plan reimplantation in a 14-month female child or 8-year male child? How will you, which will be your operative approach?
So the operative approach does not depend on the age. This only depends what you have been practicing over the last 10 or 20 years. Okay. And first, if the child qualifies for the surgery, yes, then he has to go under surgery. Whether it will go into the slot of endoscopy or for the open surgical management. Okay. So this now does not depend on which. If I do polytanolate better in 8-year-old, so I will be able to do it in the 1-year-old also if we qualify for the surgery. So age does not matter or decide what type of surgery you will do or what type of implantation you do. It is in what way you have been trained, what you have been practicing over the last 10, 20 years.
So what is your choice, sir?
Yes, I usually go for Cohen intravesical implantation.
Okay. Any reason, any specific reason for that? Because I also very much fond of Cohen's transtrigonal procedure. And my argument is it is quite having excellent results, no new hiatus formation, no extra problem with other injuries. Only problem is that my area is a stone belt area, and at times I get a condition where I have to intervene. but with these now advent of flexible scopies and all those things, I am still able to do it. But many are having a still objection. So I am trying to adapt with some other procedures like polyteno-Leadbetter, where I can have a straight ureteric course. Dr. Sripathi, what is your choice?
Oh, it's you're asking specifically about this case or a general impression?
These two cases. Let us, or you can say in general.
No. What was the other case? This is an 8-year-old child with bilateral reflux. Which was the other case? Perhaps I missed it.
Right.
This I would go in for a bilateral. When there is bilateral reflux, I would go in for a Cohen transtrigonal reimplantation, because I'm really worried about the retention when you do an extravesical bilateral reimplant. If it's a unilateral reflux in a ureter that's not very dilated, which doesn't require tapering, I'd go for an extravesical reimplant, because it's essentially a daycare procedure and you can send them away.
Okay.
But a bilateral extravesical, I would not. Whenever I have need to taper, whenever I have a bilateral reimplant, I go in for a Cohen, because I feel it's a much more reliable procedure. I do take your consideration when you have stones, but then perhaps I would leave that to you to manage.
Okay. Any specific reason for not going for bilateral polyteno-Leadbetter?
I've not been trained in the polyteno-Leadbetter, so
Again,
I'm sure I'd create complications if I get onto
that we are not trained, and even I am not trained with the polyteno-Leadbetter. Of late, in last 2 years, I started learning it and then started performing it, and I'm finding that it is not that difficult with some modifications. But that we will discuss little later. Now coming to Professor Margrit, that what is your preference?
Yeah. As I'm also an adult urologist, if you later on have an adult with a Cohen implantation and he develops stones, ureteral rhinoscopy is not possible. In some, you may use the flexible one, but in some cases, you need a straight ureteroscope. And that's the reason why I don't like it. And I trained in Mainz. So what we always did were Lisch-Gregoire procedures, because the advantage of the Lisch-Gregoire procedure is you have a straight ureteral path and you have your orifice at the same time. There are also some investigations that you can do a bilateral in the same time if you stay close to the ureter, because the nerves are a little bit further outside, but I agree, an extravesical approach in a bilateral might be dangerous. So it's our favorite in a unilateral. And when we have a bilateral reflux, I would do a stage procedure. That means that I do the beta kidney first.
Stage procedures. This is something new. Any comment, Dr. Ansari and Dr.
Yeah, maybe I just explain it a little bit more.
Okay.
What we have seen when we start on one side is that in about, I don't know why, 20%, the reflux disappears on the other side. I can't explain it really, whether it's that you pull the orifice to one side, I don't know. Therefore, we do normally the beta kidney, or if the kidney function is the same, the higher grade of reflux first. And then we repeat the voiding cystograms 3 months later and see what happened to the other side. Because sometimes if you just have a unilateral reflux, and this is what I mentioned in the case with the huge reflux and the dysplastic kidney, if you just have in the VCUG, a reflux on one side, and then you fix it, and then you repeat your VCUG, then you sometimes see a newly developed reflux on the other side. So that was the reason when I trained that we always scoped the children, but we don't do that on a routine base anymore. We did it under anesthesia just before we started the ureteral implantation.
So,
in case that we will find a distal narrow segment, so that you have to deal with a primary obstructive refluxing ureter, then a Cohen, let's say a Lisch-Gregoire is not possible, because then you need the disconnection and resection of that segment. And in these cases, we would switch to a psoas-Hitch procedure, but also then it's a stage procedure. You can't do a psoas-Hitch procedure on both sides. Concerning polyteno-Leadbetter, it's a good technique. if you use the implantation close to the base of the bladder. Because what we have seen with our transplant surgeons, they use technique on the bladder dome. And if you put the ureter just on the bladder dome, and then you have with filling and emptying a kinking and an intermittent obstruction using this technique, and we had to re-implant a couple of these ureters. So it's a great technique, but down, and we as pediatric urologists know where to put it at the base, because the part of the bladder where the ureteral implantation is has to be immobilized. That's very important to my experience.
Okay. Any further comment on this? Last question, Dr. Sripathi, as you are a robotic surgeon, would you like to do robotic reimplantation, and do you consider in that circumstances age as a criteria or no?
Just to answer the question, even in obstructive megaureters, even when you have reflux, you can robotically detach the ureter, reattach it, and subsequently reimplant it. We would, of course, use the extravesical technique to do that. What Dr. Margrit Fisch is saying is it's a very interesting concept of doing one side first and then trying to reevaluate and see whether the other side goes away. It's very interesting because it seems to be at variance with what the Americans are doing, who would, when they open the bladder, reimplant the side that refluxes, and even if the other side is normal, they would reimplant that to avoid the sort of problem of having a reflux on the other side a little later. And so that is the sort of, I think that's a very good approach to have. But if you're doing robotics, primarily, I think you can easily tackle even an obstructive megaureter. The only concern with robotics is tapering. In situ tapering is difficult. You'll have to take the ureter out through one of the port sites, taper it, and put it back. And I find that a little cumbersome. And I think you can devascularize the ureter when you do that.
Okay. Would you like to, Dr. Ansari, would you like to share your comments on laparoscopic reimplantation? Where you consider age as a criteria or no, it is just mastering the technique?
For age is, I think after 1 year, laparoscopy as well as robotic, all are doable. And in cases of, because in laparoscopy, usually it is the extravesical approach, as you must have seen sometimes doing me. And while I do mobilizing the swas or this bladder also, taking it to the swas and giving a straight tunnel, as Dr. Margit said, that makes you subsequent ureteroscopy easier. But in robotic also, I think it is up to 1 year also it is doable, because we have done few robotic reimplantation also, and
okay,
even the bladder capacity of 150 cc also.
So now it is a personal question to both of you, Dr. Sripathi and Ansari sir, that personally speaking, because you both were doing out and right open surgeries, and now you switch to the you are doing equal number of laparoscopic robotic. Would like to know from both of you personally on open forum that if you compare your results, what do you feel that after going through the learning curve, are you equating with the open results, or still it is inferior, or it is almost same? Both of you, one by one.
I do not tell my own result, because I have still limited because we started robotic late. And as you know, the robotic results of robotic implantation has also been published. And it has been seen that the results of robotic as compared to the conventional surgery is slightly inferior. Maybe that this technology is still passing through the phase of learning curve. Maybe that the volume increases in terms of the number of the cases. This should touch to the open surgery, because the suturing is as good as open surgery, and sometimes much easier than open surgery also. So it will take little time. Number of cases on this multi-center trial is very less. So there is a difference of nearly 10 to 15% inferior as to the conventional 98%. As far as the laparoscopy, yes, another thing is the time taken in robotic is also slightly higher, as well as the cost. These are the two differences. And for laparoscopy, you already know, it has not touched to the open surgery, slightly inferior, because still the number of laparoscopic cases are less as compared to the open also. And laparoscopy definitely has a steeper learning curve as compared to the robotic surgery.
Why I'm raising this question is that any failure in reimplantation surgery, the re-reimplantation surgery is always a big challenge. for
Correct.
any of the even expert urologists,
Correct.
pediatric urologists. So in that circumstances, I would like to have a brief comment from the Dr. Sripathi, and then I'm coming to Professor Margrit here.
No, I think we have done about 45 ureteric reimplants. I would still do only unilateral. I wouldn't do bilateral, because I'm very worried about urinary retention in the postoperative period, and our parents don't take to very kindly if you say, I'll do an SPC and keep blocking it and seeing whether the post-void residue comes down, and they're not very happy about it. But the unilateral reimplants, I would completely agree with Dr. Ansari in that they've really been disappointing. They've not been as good as what we would get with an open technique. I have tried to discuss it with various people, and like everything else, they say your technique is not all right. But still, I think given a choice, open surgery I feel is far better in terms of its success rates as it stands at present. But the only advantage is when you do an extravesical reimplant and you have reflux later, you can always sting them and abolish the reflux. But that's a small consolation. They're not very happy. The parents are not very happy.
Professor Margrit, last comment on this issue.
Yeah, I like to really agree with the statements. I don't see a big role of the robot in an anti-reflux procedure. A leash Gregoire is a procedure that takes you 40 minutes. And it's an incision of about 2 to 3 centimeters. So why should you dock the robot and do a lot of things? I mean, concerning the upper tract, it's different, but anti-reflux procedure, I think a very good open surgery, quick, fast, 97% success rate, why to switch?
Agreed.
Okay. So I have now last half hour where I'm precisely talking about this particular slide, why I have taken this. See, this scenario is not seen very uncommonly in my practice, that I do get this kind of a patient with the huge reflux in kidneys, with the already 2-3 episodes of febrile UTI or pyrexia before they reach to even 6 months by 6 months of age, with the raised serum creatinine. In a first case like this is the case where you can see the DMSA scan again. It's not congenital nephropathy at all. There is a photopenic areas, polar situated, right, with this absent even the uptake. So very much representative of post-pyelonephritis scarring. So this is the 6-month age children with this kind of a scenario with high creatinine, 0.6 creatinine, with the weight of 3 kg or 3.5 kg. And in another case, this is the 10-month old male child again, having this kind of a MCUG picture where you can see the huge reflux with hostile kind of a bladder with this again polar photopenic areas or absent activity as representative of scarring. So and recurrent febrile episodes. This is the circumstances. What should be the treatment is always challenging to me. Will you still continue your effort with the antibiotic prophylaxis as the child is less than 1 year? Bladders are small capacity most of the time. Doing tapering with reimplantation is very much a massive work, likely to fail. Or you will attempt tapering with reimplantation, or you will go ahead with this diversion, considering the recurrent episodes, and you want to save the child's kidney from further damage. What, Doctor? Let us start with the Gyanendra. Gyanendra, what you will advise in this kind of scenario?
Anil, it depends upon how.
Yes, please.
It depends upon how the patient presents.
Yeah,
if the child is very sick,
the patients were having multiple episodes of febrile urinary tract infection documented.
Right. If the child is very sick, then I would put in a catheter, start with culture-specific antibiotics, and see how he settles. Very often they do settle, and
but
then I would.
Both the cases were having a breakthrough infection.
They have history of infection, and the DMSA shows that there has been scarring, but this has been episodes in the past. He has presented to me now, so I would consider a good. Yeah.
No, let us assume that you was practicing with me, and this patient were put on antibiotic prophylaxis based on culture sensitivity, and they have a breakthrough urinary tract infection with this kind of a scarring in the kidneys. What you will do?
See, after circumcision and despite antibiotic prophylaxis, if there are still breakthrough infections, I would look first into how much amount of residual urine is present. Sometimes draining these bladders help. Now, if you want me to answer specifically what would be the approach and whether it should be diversion in it, if at all we are going for it, or it would be direct reimplantation, it all depends upon the bladder size. And if the bladder size is not good, then at times
you have a
these
picture of
patients,
the patient. You have a pictures of both the patient.
yeah. So on the left hand side, the bladder capacity looks okay, but the ureters are also massively dilated. So sometimes in these patients,
And mind that
on a
child
diversion.
Mind that childs are sick.
Yes, then I would prefer to put them on a diversion. And because there is bilateral reflux, I would prefer doing a vasicostomy.
Okay, perfect. Dr. Sripathi.
I would, we have discussed this extensively with a lot of people, including Philip Ransley. I'd prefer a unilateral refluxing ureterostomy on one side.
Okay.
It's simple to do, and the ureter comes down in size, and subsequent reimplantation, you can extend the incision onto your, you can sort of put the incision quite close to the bladder, use it for your subsequent reimplant. The child will be completely problem-free.
Okay, and will you attempt reimplantation in any of the case?
I would sort of reevaluate them much later, see how they are, possibly a little over 2 years. And if they still have reflux, then I would reimplant them.
Now, consider this second patient, which is having a right side one. Will you consider adding other investigations like MRI in this patient? Because see, this patient was having a 2 MCU. None of the MCU was showing clearly any urethral this thing. You think that though there is no neurological findings were there on examination, is there any need of adding MRI in this kind of a situation at this juncture? I
would rather than an MRI in a 6-month-old, I would ask for an ultrasound. Sometimes an ultrasound of the spine is quite effective in picking out a lot of details. Doing an MRI in a 6-month-old baby essentially means you have to put them under GA unless you're really worried about complex problems. Like if you want a real definition of a diastematum ileae or something like that. Perfect. Otherwise, just an ultrasound will give you a very good idea where the conus is, what is happening to it.
So both the experts are agree with these kind of a diversion. Professor Ansari.
See, this is a simple answer to do a unilateral ureterostomy, but my take is little different. You may get in such kind of massive reflux 2 types of bladders. One, this bladder which is very big. You see in both almost megacystis. It is you are comfortable. It is almost reaching above the iliac crest in both the cases. But this bladder does not need any kind of recycling. This is already over distended because of million time of recycling. So I will rather prefer vesicostomy. That will give a much comfort to this bladder. There are bladder where you would prefer unilateral ureterostomy where the bladders are small but massive reflux on both the sides. These are the bladders which will require recycling by one-sided ureterostomy. Okay. So my take will be on this on both the cases vesicostomy.
So my also philosophy is the same. I did a vesicostomy in this patient. The first patient which I treated, the second patient came. I'm showing to that picture later on in the next slide. A comment from the Margrit Fisch on this management.
Yeah, I mean, you find the different, let's say, sayings in the literature. And there's also an article of Greg Peters who said the more you do, the less good it is for the child. There is really not much data out and big series and big experience. When I would suspect any type of neurogenic bladder disturbances, the child is almost 1 year old, you could do a urodynamic investigation and see what the finding is and whether there is any possibility to do a conservative treatment. So, I mean, in the myelomeningocele, we start very early with CIC. Of course, if a child has reflux, this reflux, and you do then the CIC, you always have to consider on one side infection risk, and on the other side, at least the benefit patient has. So urinary diversion, I would only do if you cannot manage otherwise. And I mean, in the refluxing cases, we don't do it very often. We really try to manage them on a close follow-up, give them some drugs according to the underlying finding of the urodynamics. And then we will see. And when we do a high urinary diversion, we normally do a pielocutaneostomy, because then you do it up and you are far away from your later on urethral implantation. That's my philosophy.
Professor Margrit, I really agree that we also don't opt for the diversion. But here these two typical cases are there, which I also wanted to discuss at Goa when we meet in the semi-live meeting, but I was not having a pictures. Now, these are the classical cases. We do get one case at least in a year or two with this kind of a configuration with breakthrough urinary tract infection. Whatever you do, child remains sick, failure to thrive, anemic, and this thing. It's very difficult to put them on CIC, having a more increasing the risk of febrile UTI.
If you can't put,
so what is, rather than opting for the CIC, what is wrong in the temporary diversion? Like
so if you can't put them on CIC and they get recurrent urinary tract infection, you have to do a vesicostomy.
Right. So
that's the only way.
Okay. So this is your slide. Would like to
no. That's what I just mentioned.
Right. Okay.
That is what Craig Peters said.
Right. Perfect. But what about the anticholinergic? I would have to have a few words about the anticholinergic. When you add anticholinergic in your treatment regime in a patients of reflux, primary reflux.
Only
primary reflux.
If you have a urodynamic investigation and you see that it's an overactive bladder, then we would do it.
You never start empirically.
No.
Dr. Ansari. You use anticholinergics in a primary reflux patient?
Yes, I sometimes use it because all the time in infants or younger children, urodynamics is not possible, you know, because we struggle ourselves while we are doing almost 5 or 6 urodynamics in small children. It takes a lot of effort to do urodynamics in this.
Time,
Yes, lot of time. So sometimes empirically I can put, I give you the same scenario again, massive reflux with small capacity bladder, one-sided ureterostomy. These kids, they do very good in anticholinergics. Rehabilitation of the bladder with anticholinergics as well as recycling, one-sided ureterostomy. These are the candidates I prefer empirically. Otherwise, as Dr. Margrit says, if you are at the urodynamics proof, that is the mathematical proof that you can give anticholinergics. But empirically, there is a reason also.
Okay. So why I brought this issue, that I would like to show this slide, which I have discussed many platforms, that this patient was operated on some another center at the age of 10 months, and then patient never recovered from the febrile episodes. Post-operative, patient became very sick and came after another 8 months to me, and then this was the MCUG of that patient's post reimplantation, where miserably this procedure failed. And at that particular juncture, child was so sick, I have to resort for the vesicostomy. And I was really scared then when I will take these patients for reimplantation, it will be a very difficult task for me. But waiting for 1.5 or 2 years with the vesicostomy, the dilatation significantly reduced and my task became a little easier. Dr. Sripathi, your comment and on this, means as you agree with the diversion, any word of cautious to the juniors who are listening? Many of the times I've seen that they generally go ahead with the reimplantation in any of the scenarios. So some words.
No, we are having these problems at national conferences constantly with people, you know, with very little experience jumping into reimplantation in infants and suffering with the problems like this. What you're talking about is a very, very difficult scenario. We are a tertiary referral center. We see a lot of problems like this. If you were in Chennai, I would send them across to you or to Ansari. Because the more times you open the bladder and the more times you close it, you're going to enter a non-neurogenic, neurogenic bladder situation, whether you like it or not. So the important point is when you do any surgery on this sort of child, it has to be one shot that you do and you don't have to look back at it, which means you do one good reimplant, do a ureterostomy to the other side, and still keep some sort of mitrophenoff or some sort of access for nighttime drainage. And that's very, very important. And you know that you cannot tell them when you can stop that or what you will do, how much of bladder recovery you will have, you cannot say. So I would be even concerned about doing a vesicostomy in this particular case, because the more times you open the bladder, the more you expose it, the more cystitis you create, your subsequent surgery is going to become horrible.
Sir, that fear was always in my mind until I was not exposed to the vesicostomy and the subsequent reimplantation. But to my surprise, it went very well.
Very good. I think you were very lucky in this case. No, I would honestly request you to consider doing a unilateral refluxing ureterostomy.
Okay.
Whenever you have a massive reflux,
advice,
because it really settles the bladder.
years from Dr. Punjani, but since then I don't have this kind of a case.
Yeah.
But definitely, if I have a case,
that is only if your hand is really forced.
I took out one case. That was another case. Third case was there where, without doing even the DMSA scan, considering the primary huge reflux at the age of 1.5 or 2 months, my friend who is in Ahmedabad practicing along with me, I was not with him, but we definitely went ahead with this ureterostomy, and child is now almost 8-month-old, doing fantastic. And we will plan later on the further investigations and treatment.
Dr. Anil, just to re-emphasize the point that Dr. Ansari made in the previous thing,
right?
There were some questions also about anticholinergics.
Yes.
That's a big bladder. The one that you showed before is a big bladder.
Right.
What Dr. Ansari said is, after he does a ureterostomy on one side is when you would consider anticholinergics. Or you must have very good urodynamic data which shows hypercontractility. Otherwise, you wouldn't put a child with primary reflux on anticholinergics. That's a wrong thing to do, because the moment you do, anticholinergics are like, a treatment for hypothyroidism. Once you started, the pediatrician started, you don't know when to stop. It just keeps going on and on and on and on. And it's something that should be really avoided because it has very severe problems in the long term.
Now, if you look at this slide carefully, I have quoted one 92 article that is pronounced diffuser hypercontractility in infants with gross bilateral reflux. In this particular article, they have mentioned about the anticholinergic treatment.
Correct.
Right? They had done a few of these urodynamic, and there they found overactive bladder or hypercontractile bladder, and they put the patients on anticholinergics. And that is after the evidence here.
Correct.
So that brings me to the another. We have 10-15 minutes here. I'm bringing again Gyanendra. Gyanendra, this case,
Yes.
this patient, antenatally detected hydronephrosis, which was UPGO-like, no hydroureter, no ureter was not seen, bladder normal, amniotic fluid normal, all everything normal. So it was simply a UPGO-like sonography antenatally, and then
Yes.
I did this postnatal work approach. Would like to know from you how exactly this sonography is to be done and read.
Yeah. Anil, I would start with your sonography pictures, which show only a dilatation of the pelvis with virtually no dilatation of the calyces and a good parenchymal thickness. Now, if you can show a couple of the slides which I had sent to you about how we do sonography. Can we come to the next slide? Right.
You send me 3 slides. This is the first slide. This is second, and third one is the algorithm.
Yes. The second slide first. Yeah. So we are in particular very careful about how the child is hydrated, and we insist that the mothers feed their infants before they take for the child for sonography. In sonography, I would like to emphasize that we do a measurement of the AP diameter in the axial plane in both supine and prone position, and we have 2 articles, or rather 3 articles on the same regarding the evaluation of PUJ-like obstruction in these babies. The things we look at is the size of the kidney, the parenchymal thickness, the echogenicity, the AP diameter, and importantly, the calyceal dilatation in both supine and prone position. And we categorize these kidneys into 3 categories based upon what the sonography findings are. If the AP diameter decreases by more than 10% in prone position and there is no calyceal dilatation, then it is good drainage. If the AP diameter increases by more than 10% in prone position, or there is associated increase in calyceal dilatation in prone position, then it is poor drainage, and anything in between this is an equivocal category.
Okay.
We are very careful about the fact that the bladder is empty in these cases, because a full bladder can definitely increase the grade of hydronephrosis that you pick up on ultrasonography. And an important thing is this AP diameter should be measured in a transverse plane, an axial plane at the level of the renal hilum.
Okay.
It should not be done in the longitudinal.
You agree with this picture?
Yes. This is perfect. On the right hand side, there are 2 images. One is an axial one, and
Yeah.
the other one is the longitudinal one.
Yeah,
This
okay.
is axial and the other is longitudinal.
Right. So it should be axial plane,
Right.
preferably, and we should measure at the renal sinus.
Yes.
Right.
And in this patient, if the AP diameter and the calyceal dilatation show a good drainage in supine and prone position, we would prefer managing this child by keeping him under follow-up using only sonography. Though I discussed with some of these parents that do you want to have a functional evaluation, and if somebody is keen, then I do have a diuretic renogram. Otherwise, if the AP diameter, say it is 20 millimeter in supine and it falls to 16 millimeter in prone position with no increase in calyceal dilatation, my follow-up is only on sonography and I do not do a diuretic renogram.
So Gyanendra, very good, excellent. And I listened you in 2017, our Western conference at the Aurangabad. And since then, I become a follower of you. But it took me a lot of time to convince my sonologist to give that much of time. Now, I would like to ask other panelists that how much you believe in this theory that we have to preferably measure the dimension in the supine and prone and to take that values accordingly to subsequent investigations. Dr. Sripathi.
Yeah. I have heard Dr. Gyanendra's paper before, but I see a lot of patients every day and I sort of leave it to the ultrasonologist to do. I think the easiest thing for them is to look at it supine, but most of them also correlate with a prone approach. When they talk of a prone approach, it's more towards the side, particularly in infants, and looking from the back rather than a primary prone. So I don't know whether this sort of a difference between the supine and the prone makes that much of a difference, but it's something that we would like to learn.
We have been following it up for the last 10 years, and I have never regretted it.
Yes,
but I should accept the fact that I have my wife as a sonologist who takes in
tremendous
pains to do this.
But I also agree with you that we have in India that favorable circumstances for sonography is concerned. For example, in a place like Junagadh, sonologist is available next door. He become expert in getting the all pediatric urological patients. He is now agree, and the cost is nothing. It is 600 rupees. Probably in the dollar, if we take, it is hardly less than $10. And anytime it is possible, not much waiting list. So we should exploit the sonography at the maximum level. And after talking with him for subsequent few months, listening you, he started doing it. And you send me the Excel sheet. I'm feeding the data, and I will definitely send to you. And collectively, we will increase the strength, and we'll come out again with our extended finding. Dr. Ansari, would you like to comment on this sonography?
Yes, we came to know the secret why Dr. Gyanendra is focusing more on this diameter, because he is lucky that he's a sonologist, right?
Right.
But
in fact, it was her finding that made me look at it.
I congratulate both of you.
The primary author of that paper is his wife.
Okay. Yes, she should be. She should.
The Journal of Urology.
But she should be, because I congratulate both of them. But really, this such type of innovations are highly subjective. So if we can do double blind and ask the sonologist to do ultrasonography on the same baby 2 times a day, the findings will be different. This is the only yes. This is the
I would
only
agree with you, sir.
Yes.
Sir, why 2 times in a day? You do it across 2 hours, the findings will be different. But this is exactly the thing, that if the AP diameter now is 20 and the second time it is 15, and in prone it falls to 12 millimeter, the theory still holds true because kidneys drain better in prone position.
You're right.
Professor Margrit.
Yeah, I already have shown you the picture of the consensus paper at the beginning, where you see that we have the length diameter of the kidney and also the oblique diameter of the kidney, and it's at the beginning of the presentation. Yes. During the first case. I think the second slide or something like that.
Yeah, I'm coming.
So, and it's not only the intrarenal diameter, it's also the echogeneity of the parenchyma, the thickness of the parenchyma, and also calical ectasy. And in this special child, I just would follow up. So if you don't see any dilation of the calyces, yeah, that was the right one, what you have shown. Right. So we would do ultrasonography at the 3rd week of life. Okay. And then depending on whether there is a change, yes or not, we would never do voiding cystogram. Yeah, and we only would do a MAC3 investigation if there is a severe increase. And the earliest date we would do it is preferably at 6 weeks, but if possible, we would postpone it to 3 months because the kidneys are not mature enough. So at least what you get out of the result is not really reliable. So starting from 3 months, you can rely on, but not before.
So I highlight the four questions you answered here, which we are getting most commonly from the PGs. That when you will repeat the scan, sonography, you said that 3rd month. So we have a sonography done at 3 months. You have a still dilatation is there, which is almost same. In that circumstances, you are not going to do VCUG because you have a 2 serial scanning at the bladder level. There is it not showing a ureteral dilatation. I assume that you are not doing VCUG in this patient as there is no ureteric dilatation.
No, and, I mean, there is no difference in your treatment. Only before I would say if the renogram shows you that there is a UPG obstruction, then before I do the surgery, then I would do a VCUG to exclude that there is a secondary UPG obstruction due to reflux, but otherwise not, because there is no change in my therapy.
And in your timing, suppose now this patient is having at 12th week this much of a dilatation, we will subject this patient for diuretic scan at this particular juncture at 12th week, means 3 months, or you will still
not with this picture. Not with this picture. I mean,
not with this picture. You will still
wait.
No,
we just would follow ultrasonography.
Ultrasonography, perfect. Now, any difference in opinion, Dr. Sripathi, Dr. Ansari?
I would repeat the ultrasound scan at about 6 months, see what sort of a change there is. If there is a decrease, I wouldn't worry. If it was persistent, I would do a DTP at that particular stage.
Your choice is DTP or your choice is EC or MAC3?
Yeah, EC, whatever is available.
Okay.
I mean,
if MAC3 is not available in my area, but EC is available.
Okay,
so
EC
initially,
is what?
my practice was DTP, but when I learned that EC is available, then I am now opting for
absolutely EC scan. EC scan, absolutely.
Dr. Ansari, you will wait or you will subject this patient for diuretic scan?
I will just repeat the ultrasonography. If it remains status quo, then sonography will be enough. If it is decreasing, I will be happy, need not to do. Then I will increase the interval between the 2 ultrasonography.
Perfect. So we have at least consensus here that we are not going to do VCUG. We are not going to hurry for the diuretic scan. We may wait, but in this patient, the diuretic scan was done almost at the 14 renal scan at 14th month's age, as there was some dilatation was persist, and to give the final. So this was the picture, diuretic scan picture at 14 months age. In this patient, split function is almost normal, diuretic count still obstructive. What you will advise as a treatment, Professor Margrit?
As long as the split renal function is okay, I wouldn't do anything. I just would follow. Only if you see a deterioration, whether you have symptoms like urinary tract infection or a massive increase of your dilation in ultrasonography, then I would do surgery, but an intervention. But otherwise, I mean, as long as split kidney function is fine, I don't think that you can really rely on an obstructive pattern. It has to do with the bladder, so whether is the bladder catheter in or not, bladder empty or not. So I don't find really the outwash after Lasix really reliable in the very young children. So we don't rely on that.
Okay. So I just correct myself. This was done at 12 months, not 14 months, but not much difference. You have a diuretic curve which is obstructive in pattern. How much attention you will give to the diuretic curve? And if you are not going to give attention, why you are not going to give attention in this patient? Because many of my colleagues I have seen that they said the diuretic curve is obstructive, and I have waited for 1 year, and it is still having a obstructive curve. I will go ahead with the surgery, which I don't believe. you have any specific reason to not to count diuretic curve in decision making in this juncture?
Anil, there are two reasons why one should never look at the diuretic curve. In fact, I am a strong believer in the theory that T-half values and diuretic curves should not be looked at all to diagnose obstruction. There are two reasons for it. One, which Professor Margrit has already mentioned, that the bladder is often full in these patients and we don't keep a catheter. But the other more important reason is the what is called as the reservoir effect of the pelvis. See, the pelvis can be very compliant, and unless it is completely filled, it will not contract to empty. And we are just looking at the T-half value. Ideally, we need to look at where the Tmax happens, and then you give a Lasix, and you follow these patients by keeping a catheter in the bladder. I think even the most stringent centers do not follow it. So according to me, T-half and values and obstructive curves should not be looked at when you look at something diagnosed obstruction. What I look at in deciding surgery are three things: the differential renal function, the cortical transit time, and if I have to look at the pelvic emptying, I would rather look at what is called as NORA, which is a much more objective indicator of pelvic emptying rather than the T-half values.
Okay. Okay, so I have a last 5 minutes. The thing is that, I just want to ask all panelists that when these criteria are laid down about the diuretic curve, anyone you have come across any article or any literature where it is stating that it is, yes, it is true for neonates, it's true for infants, it's true for less than 2 years of age, or no, not such reading is available. To my mind, these criteria were, when it's laid down, probably they have not discussed the children less than 2 years of age. Yes, sir. Yes, Ansari sir.
Yes, see the standardization of renal dynamic scan, as Dr. Margrit rightly said, this has to be well-tempered renal dynamic scan, which states certain guidelines. Under these circumstances, then only they should be carried out. But the standardization of a renal dynamic scan has been done vis-a-vis Whitaker test. So it is true that Whitaker is an invasive test. So this has not been done in infants or young children. Most of the studies are based in adults.
Sir,
the same adult studies have been extrapolated in the pediatric age group.
But the pediatric age group, the kidneys are not matured enough to have a similar response to the radioisotope as well as to the Lasix, which we have to really keep into the consideration while we read the diuretic curve. What, Dr. Sripathi, your comment?
I'm sorry, I just missed the question there.
Sir, we may see one of the time I have seen your case. You posted one case in our old Euro education.
Correct.
The diuretic curve, the peak time reached like at this time, and
correct.
Then half is like this. What will be in subsequent scan? This has been improved. What will be your understanding of this case? So
no, the problem I think, just to summarize, the problem in most institutions that I see here which do DTPA scans is they do what's called an F0 protocol, which means they give the Lasix at the same time that they give the isotope, primarily for the simple reason that they don't want the cannula to slip out when they give the Lasix a little later. Now, this means that your child should be well hydrated when you start the study. It also means that you have to keep the child on the scanner for enough length of time. But these fellows, unfortunately, I don't want to use any enough offensive words here. They would give the next appointment within half an hour, which means essentially the time they put the child under the scanner is just 20 minutes. And for your Lasix to take effect, it takes 15 minutes. Yeah. So you have a peak value, and then you have to extrapolate. You might as well not do the study. So I think it's good to avoid looking at the T-half and looking at the curves, and instead concentrate on the transit time, which is a visual estimate as you see the pictures, and also look at the retention in the post-void picture.
Yes, sir.
Because again, all nuclear medicine units don't want you to put a catheter, because they can't be bothered with taking out the catheter at the end of it.
So I take out that second case where I wanted to discuss all these things.
Yeah, absolutely. So this is the only thing that you would look at.
To summarize very well, that
So,
we need to have a proper administration of hydration.
Absolutely.
Hydration, need to see that what time Lasix is given, the
Correct.
delayed period is taken or not. Post erect posture is erect posture film is
Correct.
there. Post void
Correct.
film is there.
Absolutely.
And then we have to consider CTT as well as this differential renal function rather than the diuretic curve. I think Margrit, you was laughing and you want to add something, or you want to?
I absolutely agree with that.
Agree,
So
yeah.
we have the same guys here. So the guys working in the nuclear medicine department are the same all over the world.
Right.
I'm very sorry, I have to leave you because I have another meeting here. It was really fun and pleasure to discuss with you, and we can repeat it maybe for let's say any other disease like valves or whatever.
So we are just about to finish, and we would like to thank you very much. We will be continue for another 10 minutes because we have only 2 slides remain. And thank you very much. As you promised, we will be back after say 7-10 days as per your convenience with the same team to finish the rest of the slides, because I have done a lot of hard work on this and I was not going to go in waste. So I'm taking promise on an open platform for all the faculties. Will be having a Nitesh and the ULTO will give us opportunity to have another session after say 8 to 10 days as per your convenience. And with that, we express on behalf of ULTOE and the Indian faculty, we express our thanks to you to join and to come and enlighten us on many of these controversial topic. I think the discussion went very well. Thank you once again very much.
Yeah.
I think other faculties also would like to thank you. Yes, Dr. Sripathi.
See you.
Thank you very much.
Thank you. And so see you next time after a couple of days. So let us come to this case. Respond to. So what do you think, Dr. Ansari? What is the basis or genesis of an observational treatment in UPGO-like obstruction?
So you asked the question.
Why I'm asking you that if you look at the 2010 this guideline published by the Indian pediatric nephrology, pediatricians guideline, then ESPU some guideline or some SPU guideline. They were not talking about the transient hydronephrosis. I taken out that slide, but I would like to have. And suddenly in 2010. They revised the guideline. If you have read that 2010-11, they came with the revised guideline where the transient hydronephrosis came on the top, which was not mentioned anywhere in the differential diagnosis when they published it in 2000, probably 2001, where our few of the pediatric urologists were also part of that panel when the pediatric nephrologist finalized this paper or guideline based on the others finding. Now, what happened in that particular decade or so? That we started believing entity of a transient hydronephrosis and started believing in observational treatment.
So if you go back 2 decades earlier, then there was a trend. Whenever you find UPG obstruction, most of these kids, they will go under surgery.
Right.
So when if you read the articles, especially from Dr. Koff's, a natural history of UPG obstruction, then the concept of conservative management started, and this basically evolved with the transitional nephrology. Transitional nephrology is a phase of initial 1 to 2 years where the kidney get mature, they acquire the adult GFR, as well as the compliance of the pelvis is also acquired. So all these factors, they may contribute to the pseudo or false obstruction or renal scan. And when we read about the natural history of these antenatally diagnosed hydronephrosis, nearly 90% of the times where these scans were frankly obstructed, they failed, and these children, they improved over a period of time. And this has been seen. If you give 100 cases, out of these, nearly 50% will improve in the first 2 years, and the remaining in the next 2 years. So over a period of 3 to 4 times, nearly 90% of the kids, they will get out of this UPG obstruction if you follow this expected management. So this is all a period of transition nephrology through which these physiological changes are held within the body of the child, and this obstruction is just gone.
Yeah, perfect. So these are the few excellent studies which were published into that particular decade by the Koff. One was by the Ullman, and then this is the finding of the Dillon from the Great Ormond Street that related to pelvic dilatation, and which has highlighted the role of observational treatment. And nothing we are going to lose with this, because see, even if the BRF less than 30, in out of 16, 15 patients recovered completely. But there is some amount of worries there with the SFU grade 3-4. Dr. Sripathi sir,
Yes, sir.
what you generally advise in a scenario where SFU grade 3-4 is there, split function is still in a normal range, you consider CTT as a strong parameter, or for judging the significant obstruction, and go ahead with the CTT if it is delayed less than more than 3 minutes, or you still wait this keep the patient in the watchful waiting?
I think if the area of interest on the EC scan or DTPA scan has been drawn properly, and you find that the kidney function is good, I think there's no harm in waiting. Except in the case that you showed, I noticed something that was very funny. In the case that you showed, that kidney is bigger than the other kidney, and so the percentage function of 49 is not the correct percentage function of that kidney. It's more because the kidney is bigger. The actual function of the kidney, once the pyeloplasty is done or the drainage is established, will be much less than what it is. So those are some of the pitfalls that you have to look at. The point that you're asking about grade 3, grade 4 is very significant. If you have a huge amount of fluid inside, obviously the function will look bigger. At that particular time, I think you have to use everything together and put it together and decide what is the transit time hugely delayed when compared to the opposite side. Is it a pelvis that is, say, 3 centimeters or 3.5 or 4? And once you do that, then function becomes irrelevant, because the function is only a reflection of more isotope laden urine staying inside. At that particular time, you would go ahead and do surgery rather than wait. But if both the kidneys are equal in size, are fairly closely together equal in size, and you find a hydronephrosis and a good function, there's no harm in waiting for a period of time. Primarily because if you don't have very good anesthetic support, I think, operating small babies might become a risk. So you might sort of delay it a little bit and see what really happens.
Gyanendra, a very good commentary, sir. Gyanendra, would you like to say a little bit on what exactly the difference between the BRF and the CTT? One is the excretory, one is the concentrating.
Yes. It's very simple to understand.
Yeah.
Way back, we all have been talking about the CTT, but interestingly, this is not a new concept. In fact, it came into picture even before the T-half values, and the article by O'Reilly had been published in, before that, Whitfield and Britton had come up with this concept, which they described as the parenchymal transit time. And they have even done studies comparing Whittaker test with this parenchymal transit time and the diuretic renogram. And they realized that CTT, that is the parenchymal transit time, is more accurate. They devised a very interesting terminology. They said that when the pelvis is not emptying, this is obstructive uropathy. But when this back pressure translates to affect the function of the tubules, that is, the tubules are unable to take back the pressure and excrete the tracer, this is obstructive nephropathy. And this is the concept of CTT, that is, what is cortical transit time? It is the time which is taken by the tracer to cross the cortex. Now, when there is back pressure effects, the tubules are subjected to higher pressure and more salt and water gets absorbed. So what remains in the tubules, that is the tracer, takes a longer time to be thrown out. And roughly it is accepted that if you look at the visual method or by deconvolution analysis, it's about 3 minutes. Anything be 3 minutes or less is taken as normal, and above 3 minutes is taken as abnormal. Though I should say that at times the way the region of interest is drawn and the films are taken, sometimes by visual method, it is difficult to make out whether it is 4 minutes or it is 3 minutes. But this is the concept of cortical transit time, that is the back pressure effects affecting the excretion.
Slide which I received from the SS Joshi sir, because we had a discussion on that.
Yes.
In Tesla Hospital, they have a dedicated software inbuilt with this radionucleide machine. And
but Anil,
they make the cortex.
Anil, I will tell you something interesting.
Yeah.
That there have been 2 studies, rather 2 studies have mentioned it as one of the parts of their study, that CTT measured by visual method is at times much better than done by deconvolution analysis because of various technical factors which come into play. So if we are looking only at the visual method of looking at CTT and using EC or MAC3, I think most of the times we would be accurate in estimating CTT.
That is what we exactly do in our practice, because we don't have that dedicated software. So we do a visual, but that is absolutely agree that works very perfectly. This is the last case where we all agree that there is an increasing dilatation. Here you can see this scan. There definitely the CTT is increased, differential function is reduced, diuretic curve is going up and up. So there is no any controversy on operating and go ahead with the operating. Now, only 3 questions here. Last 3 questions of this segment of this discussion. And thereafter we are winding. One is that best time to operate in a young kid, means infant. Till when you will be feeling comfortable operating, and or it is wiser to operate at that particular age, not before that. One, and second thing, your approach still in less than 1 year of age, which kind of a surgery you will prefer? Open, then your approach is anteriorly, posteriorly, lumbotomy. And suppose if you are not now open, then what in a less than 1 year child? Because most of the cases, most of the indicated cases nowadays we are getting of less than 1 year. Let us start with Dr. Ansari on these 2 questions.
See, the timing not only depends on the age, but it also depends the function affected of the involved unit.
You have this case. All parameters are going in favor of going ahead with the surgery early, because the split function is less than 40. Cortical transit time is increased very much. Patient is having a grossly hydronephrotic kidney with a pelvic dilatation of more than 30 millimeter.
And what is the age of this?
Age is 3 months.
3 months.
And weight is almost 5.5 kg weight.
So this is the only scan which is available. And
but that was DC, that was the scan with that patient. It came at that juncture. So
why do we want to operate just with 1 scan? Why don't we wait for another scan?
Perfect.
Yes.
But here, if you
suppose if he fails for the another scan also, the same less than 40%, still you wait. If there is no cortical thinning, the pelvic epidiameter is maintained, what is the hurry to operate this child?
I show you the whole picture. See, this is the sonography, the first sonography. This is the second sonography, and this is the sonography almost at the 3 month.
So all
central characteristics as well as peripheral characteristics are dilated. Yeah.
So it is now deteriorating with less than 40%.
Yeah. And then split function is less than 40%. Your cortical transit time is very high, means there is a completely inhomogeneous appearance of the radio tracer, as well as there is a very delay, almost not appeared completely even in the late film. And there is a lot of retention of the radioisotope in the delayed plate. So means, okay, if you want to still wait, we can definitely wait. But what, suppose in a scenario where you have a 40-50 millimeter of dilatation, till which age you would like to postpone the surgery? This is just to have a discussion and a message to the audience.
See, this is interesting. If you see, there are many studies which are showing if the pelvic epidiameter on your observational study is, if it is going more than 2.5 centimeter or 25 millimeter, there are chances that 90% of these kids will fail the expectant management. If you say that the epidiameter in this kid has already crossed 2.5, then he may qualify for early surgery.
Yeah.
Yes, he may qualify for surgery. Surgery has been done at 3 months, at 6 months safely. If you have a good anesthetist, can be done.
Okay. Okay. So, and what will be the, means you will prefer in this particular age group, open or laparoscopy or robotic? What is your choice?
Sorry, this all depends on the choice of the surgeon, because if you compare
your choice, you have, see, you was doing open, now you have done a lot of lap, and now you have a robotic.
Yes.
At this particular age group, because see, now why I'm asking, why it's a relevant question.
So yes, because most of the
less than 1 year of age.
So see, there is no advantage of minimally invasive surgery in infants. Open surgery has given as good as results, sometimes rather better results as compared to minimally invasive surgery.
Okay. So that is a very great statement from a person who is exposed to all kind of a three armamentarium open. And now in open surgery, sir, anytime do you come across a lumbotomy approach or you always go ahead with this anterior approach?
Especially if the kidney is so much dilated, a hugely dilated pelvis, I do not prefer lumbotomy because this has restrictions. If you find UPJ lying low, a low lying UPJ, then you're stuck up, then you unnecessarily increase the incision.
But sir, any specific advantage of lumbotomy in compared to the other open approach, anterior approach? Why a lumbotomy means? I have never done it, so that's why I'm interested. Any specific advantage of lumbotomy approach?
Because I do not know, it will be very difficult for me to answer. Maybe that if anybody else is doing lumbotomy, he may.
You are not doing lumbotomy, no?
Yes, I have done nephrectomy in lumbotomy, but never pyeloplasty.
Okay, perfect. Dr. Sripathi.
Yes, sir.
3 to 4 month age child.
Yes, sir.
Indicated like this for surgical intervention.
Yeah. I would straight away go in for surgery for this child, primarily because of the delay in the cortical transit that you can see on the right side. You can see a very faint outline. Then the upper the upper pole calyx is first coming into view, and then the pelvis. And also, if you look at the area of interest in this particular case, it's a bigger kidney, and even the 31% function, in my opinion, will be an overestimate. In actual fact, it might be even less than that. And the simplest thing that I found at 3 months is to do a flank approach, and that way you can sort of deal with it without any issue. The lumbotomy is not a preferred approach because the moment you extend a lumbotomy, it becomes a very ugly scar. And especially if you have a crossing vessel, then a lumbotomy becomes a little bit of a difficult issue.
Yes,
if you have a large pelvis, it becomes a difficult issue.
So that is always a query from me.
Correct.
In few of the conference, I have seen lumbotomy approach, even live demonstration. And
no, the lumbotomy is an ugly, it finally leaves a very ugly scar. It doesn't give you any advantage primarily, except the theoretical.
My practice, at least not in this age group of patients, but when I operate for 4 or 5 years of age, I do come across in 20 to 25% cases of a crossing vessel, which I think if we are badly going to miss this kind of lumbotomy approach. Another thing is that, sir, at which age you are comfortable with your experience with the robotic?
I would we have gone down to robotics till about we've done even 3 kgs, but I would be comfortable till about 6 kgs doing robotics without any issue at all.
Any specifics or advantage of robotic means
I don't know. I think primarily when you do a robotic approach, what I find is within a couple of hours of the surgery, you can actually start feeding them. And we have done well over 170 of these robotic pyeloplasties, and I find it's the recovery, the pain relief, the time to feeding, all seem to make a huge difference as far as robotic is concerned. We discharge them on the next day after the surgery, which we primarily are not able to do it with open surgery. We have to keep them at least for 48 to 72 hours.
And what is your preference, sir? You till in an open surgery and in robotic regarding the stent, drain, nephrostome?
We put a stent in everyone. We don't put a drain.
While you was doing open, you was using stent in all or no?
Yeah, we put a stent in everyone. Primarily that way you can go home and sleep comfortably.
Surgery, I use stent in all, right?
Yeah,
and don't put a drain.
You are comfortable sleeping at night after that.
Okay. So you don't put a drain. You have a stent in all patients, and you
in all patients.
Periurethral catheter.
Correct.
Just to avoid the reflux associated with the stent in the position.
Correct. We keep the catheter for 48 hours.
How many days you keep a feeding tube there in the urethra?
Usually about a day, sometimes 2 days, and then we take it out and send them home.
Okay, perfect. And any difference in the practice, Dr. Ansari, regarding these tubes?
I regularly put double J stent, and regarding removal of periurethral tube, I remove it after 48 hours.
Okay.
Why hurry once it has been put? Either you do not put. If it has been put, why not take the proper advantage? Remove it after 48 hours.
Fair enough.
I have listened few of the urologists not putting the feeding tube, but I am never feeling comfortable from my side because while I was in a training, I've seen that even on a 3rd or 4th day, patient come with the on removal of the catheter, they come with this kind of a perirenal urinoma, And when we put a catheter again and we wait for a few days, they start disappearing in a patient who are having already stent in position. So when I came to my private practice, I was used to keep feeding tube and fixing it with very well, like a hypospadias patient, sending patients for 7 days. And thereafter I was removing. But gradually with increasing confidence, I agree with both of the speaker that I keep it for 48 hours and thereafter I'm taking out. Not seen any kind of a major issue. Gyanendra, any difference in the practice?
Well,
You are not using the stent.
I don't use stents about 95% of the times. I put stents 5% of the times. So my patients, infants who are not toilet trained and below the age of 4 years, they do not have a stent, no catheter, it's only a drain. The only exception to this is if it's a very large kidney, because I've seen that large kidneys, the pelvis takes a long time to start contracting in a way, and then there are problems. So in those scenarios, I put in a stent. Otherwise, I don't put a stent.
Okay. Now, suppose if you not put a stent and you have a persistent drain for a while, means for extended days of 4 or 5, 6 days, how you tackle? Means you just wait, discharge the patient with the drain in position, or you just keep the patient till the drain dry, or you do some intervention?
Right. At my place, most of these patients would never go home with the drain.
Yeah.
They would insist that they stay
worry
back till
that
the
if
drain
you
is
don't
removed.
keep a stent and if you have an extended period of a drain, you have to
Yes.
hold the patient in the hospital. Means
Yes.
in that case, how they behave, means they would like
most of the time, see, this scenario I have faced about only twice in my last 20 years of practice.
Okay.
And on one occasion, it has been an attempt to put a stent where the stent did not go, and then I kept a feeding tube across the anastomosis, and that feeding tube got pulled out within 6 hours. So the drain persisted, which was expected, and it persisted for 12 days. But the other key scenario was very interesting, that the baby presented with massive post-operative diabetes. And that came as a surprise to me that a 3-month baby was pouring in 400 ml from the drain and 100 ml from perurethral, which was a surprise. 800 ml for a 3-month-old baby is surprising. But when I went in and reviewed the literature, there are case reports where post-obstructive diuresis, even when there is unilateral hydronephrosis, can cause this. And the indication for suspecting such a scenario is if it's a very tense pelvis, very massively grossly dilated pelvis, and gross hydronephrosis. So in these patients, I always put in a stent, but otherwise I don't put in a stent, and I never regretted it.
With this, we are winding this session. To catch up the time lost in between because of internet problem, we extended some period, some time. Would like to have a final comment from each panelist regarding this particular episode, or would like to have one more session or anything, whatever you want to like to comment. Dr. Sripathi.
It's been great being with everyone and sharing our views and ideas, and I'm surprised at how many areas we all think alike. And it'll be a pleasure actually to have further sessions like this. We'll be delighted to join you. Thank you for the opportunity.
Dr. Ansari.
Yes, this is also true, but I enjoy more where you are having difference on different approaches.
Yes.
So those are the area we want to explore further.
Absolutely.
Definitely.
Yeah,
we have many of these slides, but this was a first attempt with this team. So we'll be bringing much more. See, pediatric urology is the area where we have ample of opportunity to have debates on each and every aspect, and we'll continue doing with this. I hope you liked it, Professor Ansari.
Yes, true.
We'll
because
be having
otherwise,
a session with you very soon.
so otherwise the guidelines have become so monotonous. Many a time they may not be truly applicable to all patients, especially in Indian patients also.
But to
unless
my
we have
surprise,
some
sir, today we were having a lot of consensus, and we have given a lot of concrete answer to the viewers, which is probably not even seen in the conferences. When we finish and we go for a cup of tea, they generally ask that, sir, we could not conclude from this session. Probably today we have given at least some concrete, non-controversial consensus things.
True.
Right.
Anil,
Gyanendra,
I would say,
last comment.
yeah, Anil, really enjoyed this session, and it was an excellent collection of cases. I think we should have one more session, and as there were variety of cases with reflux, I think we can include cases with bilateral PUJ obstruction diagnosed prenatally and PUJ in solitary kidneys.
See, I had 2 cases, but I was knowing that it will be difficult to hit those cases. But I have already 2 cases which I demonstrated at the Bangladesh in this kind of a similar case discussion session, and we'll bring it. So thank you very much, all of you, to take come to this platform to have this case-based discussion, and definitely we'll come again with the second episode with the help of Nitesh and his team on ULTOE. So stay tuned, viewers, and thank you very much, all panelists, for giving your significant time of this evening. Thank you very much.
Thank you.
Thank you.
Dr. Anil.
Thank you.
We wind up this.
Dr. Sripathi and
Bye.
Dr. Gyanendra, I myself learned a lot today.
Oh,
Yeah.
Okay. Okay.
pleasure, sir. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you so much.
कैसे करना है